millimeters of mercury, which is a significant difference and change. This posts were taken from the American Heart Association guidelines, summarize what I have mentioned in the DASH diet. Moving to guideline for diabetes, the ADA recommend to refer adults with overweight or obesity at high risk of type 2 diabetes for intensive lifestyle behavioral change program that goal or aim to maintain the weight reduction of at least 7% of the initial body weight. This can be achieved through healthy lifestyle modification like healthy diet, healthy reduced caloric diet, and physical activity of 150 minutes or more per week. There are various dietary patterns can be used in patients with type 2 diabetes and pre-diabetes. Also can be used to prevent the type 2 diabetes and pre-diabetes. However, some trials has been shown that the Mediterranean lifestyle or Mediterranean diet and low carb diet and the DASH diet has shown a beneficial effect in improving the glucose metabolism and lowering the risk of developing type 2 diabetes and cardiovascular disease. Also, the ADA recommend to screen for pre-diabetes and type 2 diabetes at the age of 35 in order to detect the early cases of pre-diabetic patients. We offer to refer them for a primary preventive interventions. The CDC recommendation regarding diabetic patients is recommend to eat well. This emphasizes that they should focus on fruits and veggies in diet and whole grains in diet and avoid the trans fats, sugary beverage, the sweetened beverage and salt. In addition to that, they recommend to engage in a moderate intensity exercise for at least 150 minutes per week. As I mentioned before, also the U.S. Preventive Services Task Force recommend to screen for pre-diabetes and type 2 diabetes in adults starting from age 35 years and try to detect the early case of pre-diabetes and refer them for primary preventive interventions and lifestyle modification. According to the American College of Lifestyle Medicine guideline for diabetic patients, it's recommended to use the low-fat, whole food, plant-based diet to reverse and minimize the insulin resistance. And the goal here is remission rather than the management, using the intensive lifestyle intervention as a primary component of the medical care. At last, the Saudi guideline has recommended For people with type 2 diabetes and overweight and obese, to lose weight of more than 5%. And this can be achieved through a healthy diet and physical activity. And there are various eating pattern again can be used in patients with type 2 diabetes and the pre-diabetic patient. However, the Mediterranean diet has been shown to be to improve the glucose metabolism and lower the risk of type 2 diabetes and cardiovascular disease. For the physical activity, the Saudi guideline recommend that the adult should engage in a moderate to vigorous intensity exercise for 50 minutes or more, 3 days per week. For children and adolescents to engage in moderate intensity aerobic exercise and muscle strengthening activity and bone strengthening activity for at least 60 minutes or more, 3 days per week. And thank you.
Thank you, Dr. Ghazal, for your informative lecture. Before we jump into our next session, just a kind reminder, be in the lookout for the Q&R code to scan it for the question and for the evaluation. One for the question, the other one for the evaluation. You can click on whatever speaker you want and then put your own question. Your insight is highly appreciated, so please do it. Our next topic will be about GERD, gastroesophageal reflux disease, and its management through the lifestyle modification. It will be presented by Dr. Muna Zeki. She is a consultant and a trainer at family medicine at King Fahad Medical City. Please welcome with me Dr. Muna.
Assalamu alaikum wa rahmatullahi wa barakatuh. First, I would like to express my gratitude to the excellent organization of this committee and to the committee organizing this event. And today we will discuss the lifestyle modification in the treatment of gastroesophageal reflux disease. First, we'll start by definition GERD. GERD is a condition in which the reflux of gastric contents into the esophagus results in symptoms and or complications. GERD is objectively defined as the presence of characteristic mucosal injury seen at endoscopy, and or abnormal esophageal acid exposure demonstrated by reflex monitoring study. Prevalence of GERD, as was found to be 20 to 20% in Western world and less than 5% in Asia. A SWOT study estimated that the prevalence of GERD among the Saudi participants was 28.7%, and the prevalence of GERD among the Saudi population was higher than that in Western countries and East Asia. So we have the highest prevalence. Okay, now regarding the pathogenesis of GERD, the pathophysiology of GERD include a poorly functioning esophageal-gastric junction, impaired esophageal acid clearance, decreased salivary production and delayed gastric emptying, and esophageal hypersensitivity in some of the cases. And some of the risk factors of GERD, among others, are family history, obesity, pregnancy, hiatus hernia, decreased or delayed esophageal motility, Zollinger-Ellison syndrome, xerostomia, and alcohol. And in some cases, drugs could cause GERD symptoms. Okay, GERD manifests classically as heartburn, which is typically described as a burning sensation in the retrosternal area, most commonly experienced in the postprandial period. Heartburn is considered troublesome for if symptoms occur 2 or more days a week, and the other clinical manifestation could be a regurgitation of acid and food. Okay. GERD can manifest as well as atypical symptoms or extraesophageal symptoms, mainly ENT and pulmonary symptoms. It's very important that in the absence of classical symptoms of heartburn and regurg, other disorders need to be excluded before attributing the symptoms of GERD, like the patients complaining of central chest pain. We have to rule out cardiac problem. So the least common or atypical symptoms of GERD reported to include water brush, dysphagia or odynophagia, chest or epigastric pain or discomfort, satiety, burping or hiccup, bloating, nausea or vomiting, symptoms of extraesophageal reflux symptoms, like laryngopharyngeal reflux, which is potentially associated with GERD-R. As I mentioned before, like ENT symptoms, sore throat, recurrent otitis media, laryngitis, sinusitis, hoarseness, and pulmonary, like chronic cough, wheeze, and asthma. And alarming features which are suggestive of gastrointestinal malignancy include new onset of dyspepsia in patients 60 years old and older, evidence of GI bleeding, dysphagia, odynophagia, gastrointestinal cancer in first degree relative, iron deficiency anemia, anorexia, unexplained weight loss, and persisting vomiting. Some of the GERD complications, or the most common GERD complications, are erosive esophagitis, esophageal stricture, and Barrett's esophagus, which is a high risk of developing malignancy. Okay, regarding the diagnosis of GERD for patients this is the recommendation of the American College of Gastroenterology 2021. There is no gold standard in the diagnosis of GERD. Thus, the diagnosis is based on a combination of symptoms presentation, endoscopic evaluation of esophageal mucosa, reflex monitoring, and response to therapeutic intervention. For patients, let us start by the recommendation of the American College of Gastroenterology. For patients with the classic GERD symptoms of heartburn and rigors who have no alarm symptoms, ACG recommends 8 weeks of empiric PPIs, which is proton pump inhibitors, once daily before meal. It recommends attempting to discontinue the PPIs in patients whose classic GERD symptoms respond to an 8-week of empiric trial of PPIs. In patients with a chest pain who have had adequate evaluation, as I mentioned before, to exclude heart disease, objective testing for GERD, which is endoscopy and reflex monitoring, is recommended. It doesn't recommended that use of barium swallow solely as a diagnostic test for GERD. It recommends endoscopy as the first test for evaluation of patients presenting with dysphagia or other alarm symptoms. We start by endoscopy, like weight loss, GI bleeding, and for patients with multiple risk factors for Barrett's esophagus. In patients for whom the diagnosis of GERD is suspected but not clear, an endoscopy shows no objective evidence of GERD, ACG recommends reflex monitoring to be performed, but it should be off therapy of PPIs to establish the diagnosis. It suggested against performing reflex monitoring of therapy solely as a diagnostic test for GERD in patients known to have endoscopic evidence of Los Angeles grade C or D reflux esophagitis, or in patients known to have long segment Barrett's esophagus. Okay, continuing the diagnostic test, there is, as we said, the endoscopy, which is indicated for alarm symptoms or symptoms suggesting complicated disease, such as atypical, persistent, or relapsing symptoms. So if you have alarming features, don't start with the PPI as a trial diagnostic therapy. No, start by endoscopy to rule out these complications. May also esophagitis may show the endoscopy may show esophagitis like erosion, ulceration, stricture, or Barrett's esophagus. For the esophageal capsule endoscopy, usually it's not done that frequently. It involves swallowing capsule endoscopy to visualize the esophagitis. It doesn't request sedation. It may show esophagitis or Barrett's esophagus as well. For the ambulatory pH monitoring, it can demonstrate abnormal excessive esophageal acid in the absence of esophagitis. AGA recommends ambulatory pH or impedance pH monitoring while off PPI therapy for 7 days. pH less than 4 or more than 4% of the time is abnormal. This is by definition to diagnose the GERD. Combined impedance pH testing, which is more frequently done, it can quantify exposure to esophageal acid and identify reflux events regardless of the acidic content to assess correlation with the symptoms and may detect acid or non-acid reflux events. For the diagnostic test, we will, okay. The last test is the esophageal manometry. Manometry evaluates esophageal contractions and lower esophageal sphincter function. It may detect esophageal motility disorders such as if we are suspecting achalasia or diffuse esophageal spasm. Barium swallow esophagogram. Barium swallow may be used for a patient with dysphagia or whom endoscopy is contraindicated or unavailable, or as a complement to endoscopy. It may exclude other causes of dysphagia like cancer or tumor, which is obstructing the esophagus, and it can cause dysphagia. Now, the most important part of our presentation is the management of GERD, which could be by lifestyle modifications, medications, or surgery. Starting by the lifestyle management, and starting by the weight. Sorry. Weight gain has been associated with a new onset of GERD symptoms, even in those with normal BMI at baseline. Obesity increases the risk of GERD, possibly because of a combination of eating a diet high in fat and other food that promote reflux, increased intra-abdominal pressure that promotes reflux because of the increased intra-abdominal fat, physiological changes induced by products of visceral fat. In a population-based study in Norway, assessed weight and GERD symptoms at baseline and 10 years later, identified a dose-dependent improvement in GERD symptoms with weight loss. Continue with weight. Prospective and cohort studies also have shown improvement in GERD with weight loss. One study documented 40% reduction in frequency of GERD symptoms in women who reduced their BMI by 3.5 or more compared with controls. A meta-analysis suggested that weight loss in overweight patients, avoidance eating before going to sleep, and smoking cessation are effective in the relief of GERD symptoms. Okay, so what are the foods that should be avoided, or at least the patient can reduce the intake of them. ASCG recommends to eat smaller meals and cessation of foods that potentially aggravate reflux symptoms, such as coffee, chocolate, carbonated beverage, foods with high fat content, spicy food, acidic foods such as citrus, like lemon or orange, tomato, and definitely alcohol. Okay, continuing with the diet. Sorry for that. This one is not working. Okay. Supporting data from these recommendations are limited and variable, often involving only small and uncontrolled studies and rarely at the only intervention, making interpretation and definitive recommendations difficult. In lab studies, coffee, caffeine, citrus, and spicy food had little to no effect in lower esophageal sphincter pressure. However, some of these items might have irritant effect that could evoke GERD symptoms without influencing reflux. ترى الصور أهم شيء عندي. Okay, a recent article using data collected from the prospective nurses' health study evaluated women without a known history of GERD for the impact of coffee, tea, soda, milk, water, and juice on reflux symptoms. 6 servings of coffee and soda were associated with the increased reflux symptoms compared with the 0 servings per day. By contrast, milk and juice were associated with increased reflux symptoms despite the acidic nature of some of these beverages. Substituting water for 2 servings, coffee, and soda was associated with a decrease of GERD symptoms, suggesting that substitution of water for these beverages may be helpful in the management of GERD. ACG recommends to avoid meals within 2 to 3 hours of bedtime, which is a low level of evidence, but it is a conditional recommendation, strong conditional recommendation from the ACG. The timing of food intake can also affect the GERD symptoms. A short interval less than 3 hours between eating and bedtime or lying supine is associated with increased GERD symptoms and the need of medication. So ما ناكل وننام أو ننام أو ناكل نستلقي على طول. A meta-analysis suggests that weight loss in overweight patients, avoidance of eating before going to sleep, and smoking cessation are effective in the relief of GERD symptoms as well. Multiple studies, including several recommended controlled trials, have demonstrated improvement in nocturnal GERD symptoms and nocturnal esophageal acid exposure with the head bed elevation or sleeping on a wedge. Which is better, to sleep on the right side or on the left side as a management of GERD or to avoid GERD. Left, صح. Left side. Also compared with lying left side down, lying right side down increases nocturnal reflux and reflux after meals, reason because of the right side recumbency places the esophageal gastric junction in a dependent position relative to the pool of gastric content that favors reflux. Thus, patient might be avoided. Thus, patients might be advised to avoid sleeping right side down مع إنه السنة النام على اليمين لكن الأفضل للجرد to sleep on the left side. In large cohort studies, smoking cessation was shown to improve GERD symptoms. Patients in smoking cessation study had GERD symptoms measured by a validated questionnaire, and those who successfully quit smoking for a year had 44% improvement in GERD symptoms, and compared to 18% in those who continued to smoke. And a cohort study found that smoking cessation may be associated with improved reflux symptoms in normal weight adults with GERD, and at least weekly anti-reflux medication use, but not in adults with less than weekly anti-reflux medication use or in those overweight obesity. So smoking cessation can be effective in mild intermittent GERD. Other measures that have physiological basis but have not consistently been demonstrated to improve reflux symptoms include avoidance of tight-fitting garment to prevent increasing, avoidance of tight-fitting garment to prevent increasing the intragastric pressure and gastroesophageal pressure gradient, promotion of salivation through oral lozenge chewing gum to neutralize reflux acid and increase the rate of esophageal acid clearance. Abdominal breathing exercise to strengthen the anti-reflux barrier of the lower esophageal sphincter. This is a summary and strength of recommendation of ACG. I will skip it now because it's the same points which we mentioned before. You want to? خلص الوقت. Okay. Now for the medication and the mild and intermittent symptoms. بس 5 minutes. Okay. And the mild and intermittent symptoms. Mild, it means that the GERD occurs 1 time per week, okay? Less than 2 times per week with no complications like esophagitis and endoscopy. So the mild and intermittent symptoms will start by antacids, by histamine receptors. For severe or frequent symptoms or erosive esophagitis, severe or frequent symptoms more than 2 times per week, with evidence of erosive esophagitis or persistent GERD. Okay, we start by PPI for 8 weeks, which is the first line treatment of GERD. Then we will evaluate and etc. You can review it from UpToDate or any other sources. And ending by the anti-reflux procedures. The most common indication of anti-reflux procedure is severe symptoms, incompletely controlled by optimal medical therapy, non-GI symptoms, and despite successful medical management, patients who are intolerant or non-compliant with or do not wish to continue lifelong medical therapy may opt for anti-reflux surgery due to the quality of life consideration. There is the endoscopic surgeries, there is laparoscopic surgery, and the most important thing طبعا for this lecture that we discussed, the lifestyle modifications, okay? And I wish that our presentation was beneficial and informative. Thank you very much.
Great presentation, Dr. Mona. I hate to interrupt it. Thank you. Now, switching gear to a very interesting topic about the allergy and lifestyle modification and its relation to the allergy. It will be presented by Dr. Faiza Al-Ghanmi. Dr. Faiza, she is a consultant in clinical immunology and allergy at King Fahad General Hospital. Please welcome with me Dr. Faiza to the stage.
Assalamu alaikum, everyone. Assalamu alaikum, everyone. I'm so pleased to be here with you today in this wonderful meeting. And it's an amazing city of Hail. Today, I'm going to talk about the allergy and lifestyle interaction. In my topic, I will be covering some points, including the incidence of allergic diseases worldwide, pathophysiology overview of allergy, and also the effects of lifestyle factors on allergic condition, including diet and nutrition, physical activity, and housing factor. The prevalence of allergic diseases worldwide is rising dramatically in both developed and developing countries, with about 40% of world population being affected by one or two allergic condition. This markedly affecting the quality of life of those individuals, their family, and negatively impacting the socioeconomic welfare of society. In the state, CDC documented that more than 50 million of American individuals diagnosed with allergic condition. 24 million of them have seasonal allergic rhinitis, and also patients with asthmatic, they do have 85% of them would have also comorbid allergic rhinitis. This also have some economic impact on the society, with more than 3 million missed working days per year of those affected individuals. Annual cost of about 8 billion being spent for medical care of those individuals. The environmental factors are broad, including pollen, molds, dust mites, and animal dander, as well as some cockroach and mice. Have a bit of sort of overview of how the allergy started. We know that the allergic diseases are a set of chronic inflammatory condition affecting the lungs, skin, and nose epithelium, characterized by the two important finding, which is abnormal IgE, almost raised IgE against certain allergens, as well as what is called Th2 cytokine-mediated immune response. So the signature words here is Th2 response for the allergic diseases. As you can see here, pointer, sorry. As you can see here, the allergen that we are exposed to are taken by our dendritic cell and basically presented to naive T cell to induce its proliferation to what is called Th2 subset. Why it's called Th2 subset? Because it has a very specific cytokines. It's called Th2 cytokines, namely IL-4, 5, and 13. IL-4 will induce the production of allergen-specific IgE from the B cell, as well as induce the sensitization of mast cell with the specific IgE on the top of them, as well as we're having activation of other vector cells involved in allergic reaction. So we know where the pointer is? The pointer? Looking at the effect of lifestyle factor on allergic conditions, we will go through mainly on diet and nutrition. We'll touch upon on physical activity and environmental factor. So the role of the diet and nutritional status in allergy basically there has been a growing interest in dissecting the connection between nutrients and their metabolites as well as the allergic reaction. So the dietary factor not only affect the development of allergic diseases, but also involved in influence the disease course and severity. It has been documented that Western diet is recognized as environmental risk factor for developing the allergic diseases, whereas Mediterranean diet is protective one. Appreciate if you can have a look at this a little bit of a busy slide. We know that the dietary components and its metabolites have a direct role on all the aspects of allergic reaction. As you can see here, the dietary factors have a direct impact on the epithelial barrier integrity with the release of TSLPs, which is one of the most important signaling cytokine for Th2 allergic reaction. It's also involved in the innate immune response as well as adaptive immune response with the stimulation of this Th2 cytokines. It also has impact on the tissue inflammation and remodeling as well. Diet as well have a critical role in determining the gut microbiome. And not only that, but also the diversity, the composition, and metabolites of the gut microbiome. And appreciate if you look at the blue arrow here, indicating that the bacterial metabolites exerts its function on distant organs. The epidemiological and clinical as well as animal model studies documented that the Western diet, which is a pro-allergic diet, consists of high calories, animal fat and protein, saturated fatty acid, and medium chain fatty acid, will promote the allergy as well as increase the severity of allergic symptoms. On the other hand, the Mediterranean diet, which is anti-allergic diet, consists of more of fruits, veggie, dietary fibers, dietary flavonoids, as well as vitamins, will be protect from the allergy as well as reduce the severity of allergic reactions. The effect being exerted at a different level at epithelial cell, stromal cell, and also innate lymphoid cells, and the dendritic, and so on. By increasing the TSLP production by epithelial cell, as well as Th cytokines of the innate lymphoid cell. Also, it stimulates the dendritic cell and macrophages, the pro-inflammatory phenotype, increase the production of IgE from the B cell, and drive the Th2 cytokines and mast cell degranulation, and the opposite effects happen in case of a Mediterranean diet. Looking at the protein and amino acid, has been found that high protein diet associated with increased risk of allergic sensitization in a mouse model for airway hypersensitivity. Also, if you restrict the diet in those mice model for atopic dermatitis, this will delay the onset of spontaneous dermatitis in those animal models, which resembles the human AD. Essential amino acid as tryptophan and L-glutamine also plays a critical role in the immune function, in which if there's any abnormal metabolism of these two amino acids will influence the severity of allergic diseases. It's been found that the higher serum tryptophan being found in the patients with the allergic rhinitis as well as an asthma, while is low L-glutamine has been linked to the patient with allergic rhinitis as asthma as well. Looking at the lipids, the amount of dietary lipids and type of fatty acid influence the allergic reaction, with high total fat and animal fat and saturated fatty acid, and 6 polyunsaturated fatty acid and medium chain fatty acid, all are a risk factor for allergic disease. Whereas monounsaturated fatty acid and omega-3 fatty acid have protective properties. They have been found that high animal fat and saturated fatty acid associated with allergic rhinitis in adults. However, if you are consuming high amount of monounsaturated fatty acid, is associated with reduce of asthma risk, being documented in like several studies, including the one done in with the Italian adults and teenager in Taiwan. For the a mouse model of atopic dermatitis, if they are fit with high-fat diet, they actually will actually increase the serum TSLP and develop atopic dermatitis spontaneously. Why? Because a high-fat diet increase the bile acid and alter the bile acid metabolism will also alter the signaling of the receptors in those in the skin lesion of those animal model of atopic dermatitis. They have also experimenting lowering these bile acid by giving anti-cholesterol agents like cholestyramine, and then they have found that it's reduced epidermal hyperplasia and decreased Th2 cytokines, indicating that the Western diet will alter the bile acid metabolism and contribute to these dermatitis lesion in those animal models. On the contrary, we have the omega-3 fatty acid, the good fatty acid, basically show beneficial effect on allergic inflammation. It's improving the skin barrier function of atopic dermatitis mice, attenuated their symptoms. In human mast cells, has been found that the byproduct of the omega-3 fatty acid, EPA and DHA, will suppress the Th2 cytokines in those cells and possible protective role from Th2 inflammation. In contrast to that, a long-chain N6 fatty acid, omega-6 fatty acid, drive arachidonic acid and increase tumor necrosis factor and prostaglandin, and hence increase the severity of the allergic condition. Dietary fat has really important role, not on its own, but also along with the gut microbiota, because both the amount and the type of dietary fiber affect the susceptibility of the allergic airway inflammation and the severity of inflammation, in which how we are protected, because the dietary fat actually metabolized by the bacteria in the gut to produce pituitary, which is a short chain fatty acid. The effect of piturates basically have a very good effect on the gut-skin axis as well as gut-lung axis and regulate the allergic response. Dietary fiber modulate not only in the like from the gut affecting distant organs, like for example in the lung, as we are interested today in allergic diseases. It's basically inhibit the histidine acetylase and induce the prevent the development of allergic diseases. So short chain fatty acid, particularly piturate, has a very various role in the immune cells as well as the structural cell. So if we supply these short chain fatty acid, the drinking water of the animal models of bronchial hypersensitivity, it's basically restrain the development of Th2 cytokines in virus batches of those animal model. In human, they have been found that the piturate has been found to be inversely associated with the house dust mite specific IgE level in childhood asthma. Also, they have found that in infants whom having the high incidence of allergic diseases, they do have enzyme deficiencies that work on dietary fiber to produce piturate production. And recent study in Japan showed that not only the products and metabolites, but also the diversity of the gut microbiota has a role. And as they have been documented that patients with allergic rhinitis, they do have more of like that we could say bad bacteria like E. coli compared to the good bacteria, which is, for example, like in the Brevota. Pectin is a water-soluble, highly fermented dietary fibers. Also, when it's fermented, it produces another short-chain fatty acid called propionate, which has been documented that enhance the bone marrow homeostasis and reducing more tolerogenic dendritic cell, and hence reduce the possibility of Th2 cytokine-driven inflammation. Water-insoluble fibers, on the other hand, like cellulose or inulin, that actually induce the production of the serum bile acid, which trigger the eosinophilia in the colon and lungs. Not only that, but also increasing the bile acid will interact with certain receptors and increase in the stromal cell, increasing the secretion of IL-33 and hence promote type 2 cytokines. Going to the flavonoid and phytochemicals also has important role in the allergic condition and mainly found in the vegetable and fruits and so on. So it's the major dietary flavonoids is the quercetin, which is found in fruits and veggie. They have anti-inflammatory effect and anti-allergic effect by reducing the serum IgE, reducing eosinophilia and epithelial stromal thickness. There's another flavonoids as well, like leucoserine, being actually taken from the Laker rice, and also has a protected role in the mouse model from atopic dermatitis. Resveratrol as well has been studied to inhibit the mast cell activation and show beneficial effect in treating allergic condition. They also documented in the study that providing 15 gram of a barley-based formula, which is very rich in phytochemicals for 14 days, proved to be significantly reduce all symptoms in patients with allergic rhinitis, with even better result than fixofenadine, which is antihistamine, in terms of controlling their nasal congestion, postnasal drip, and headache. Vitamins and minerals have also an important role in prevention or in protecting against allergy, namely A, C, D, E, iron, and zinc. The vitamin D has inhibitory effect on the bronchial smooth muscle as well as the human airway smooth muscle, with the protective effect against allergic asthma. It has been found that that children and adolescents with vitamin deficiency of less than 15 nanogram found to be associated with higher level of a specific IgE to allergens. And it's been also documented that has effect on those patients or children with the gastrointestinal food allergy, in which that they do have delayed resolution of their eosinophilia in the gut. Iron deficiency, surprisingly enough, for the last few years, it has been linked to the allergy and allergy prevention. As you know, that the iron deficiency, which is due to iron deficiency anemia, actually, is affecting a third of the world's population. Why the iron is very important? Because the concentration of the iron in the mast cell is perceived as a regulatory mechanism. So if there is low iron, then it will be perceived as a danger signal, and then the mast cell will degranulate, causing allergic symptoms. So immunologically, iron deficiency leads to activation of antigen-presenting cell, promote Th2 cytokine. Zinc also is important factors in which that the zinc deficiency related to a great, airway hypersensitivity compared to the normal diet, the normal concentration of zinc in the diet. There's interesting pilot studies, double-blind, placebo-controlled pilot study being conducted on atopic individual using a micronutritional supplements, and they are looking at the role of ameliorating the atopy by compensating this micronutritional deficiency in immune cell. In this study, they actually include 51 women with allergic rhinitis. Mainly, they do have allergy to pollen and grass, and they give them a questionnaire before and after. They supplement them. 25 of them supplement them with the what is called a holo BLG, which is a supplement that has a beta-lactoglobin as a carrier for these micronutrients, and they compare them to the placebo group. The micronutrients being included in this were the iron, polyphenol, retinolic acid, and zinc. Have been noticed that significant reduction in their nasal symptoms, about 40%, 40% improvement in patients whom treated with this micronutrient supply, compared to the 31 of the placebo group. Trace element also has an important role, as the selenium is anti-inflammatory as well as having protective role and have an anti-allergic role as well. The physical activity also has been linked to the incidence of allergic diseases, with the interesting studies being documented in Italy, including 780, 690, almost 90 school children aged from 4 to 15, and they got them from two different socio and sort of like geographic two different geographical environments. They do have a group of the children for almost 480 from the urban environment and lifestyle, like in Rome, like a major city with 3 million inhabitants. Compare them to the children coming from a small village in North Italy called Maranello. They basically questionnaire interview those kids with their family, and then they did the clinical examinations, biometric analysis, as well as skin test for allergens in those children. They also looked at their level of activity as well as BMI. There is an interesting finding that the children from an urban city like Rome, they do have overweight of 15%, while those from the village, they are only 10%. Definitely, they have sedentary activity in the town, in the city of Rome. They have sedentary activity like TV, watching video gaming of 83% and 35% compared to 67 and 9%. They have found that the incidence of allergic respiratory disease as well as conjunctivitis is basically in those pediatric population were higher. Comparing, as you can see, the two prevalences in these two groups, and they link it also to the physical activity and overweight. Means that the less physical activity, the more prevalence of allergic symptoms. Housing characteristic and lifestyle behaviors and allergic diseases are not really touched a lot on in studies, but there's few studies.
1 minute, Doctor.
There's a few studies regarding this done in Shanghai, looking at the association of building characteristic and the behaviors with allergic diseases. And they have then found the allergic symptoms of those participants. They have, meanwhile, looking at the building characteristic, environmental exposure, and lifestyle behavior. And they have been actually documented there's association between various factors and symptoms of allergic diseases. Looking at for example, the resident type with a detached house and multi-story building, they found the incidence is more in the multi-story building. They also find it higher in urban cities, as you can see here. I appreciate it's not that clear compared to urban and suburban areas. Also looking at the size of the building, the smaller the size is the less the prevalence of allergic symptoms. Looking also at certain, for example, factors like adding new furniture into their houses has been also linked to increase the prevalence of allergic diseases or allergic symptoms, I mean. So also looking at the dampness level at the certain factors at home, the more the dampness is, the higher the incidence of allergic symptoms. Also looking at the location of the houses to the traffic area. So the far the house from the traffic area is, the less the prevalence of allergic symptoms. Also the animal that like, for example, cockroach or flies, for example, mosquito flies, being also associated with the higher prevalence of allergic symptoms. So take-home message today is the prevalence of allergic diseases globally has dramatically increased, with 40% of our population affected by allergy. And the burden of this allergic condition is not only on the allergic individuals, but affecting their families, then negatively impacting socioeconomic welfare of the society. So it's effective lifestyle management is a powerful tool for the allergy sufferer to regain control of their life and minimize the impact of the allergens by identifying the trigger, implementing healthy diet, and creating allergy-friendly home, improving the indoor air quality. All these will have helped those individuals to significantly improve their quality of life. Thank you. Thank you. Done right.
Thank you, Dr. Faiza. I am really hoping that we have, let's say, extra 30 minutes to discuss your presentation that's full with, impacted with the really important information. Now, I'd like to ask our speakers to come up to the stage for the discussion panel. So first of all, I really enjoy the discussion so far, and it seems I'm not the only one who enjoyed it. So I have a lot of questions, but I'm gonna select some of the question for the purpose of the time. And I'm gonna start up with Dr. Faiza. Dr. Faiza, you have a lot of information in your presentation, and it seems that me and the audience also agree in one point, like I have a lot of questions regarding the same point. In your presentation, you mentioned that, yes, high protein diet will increase the risk of type 1 allergy, and I think that was an animal study, if I'm not wrong.
Yeah.
So the question is, does that mean that keto diet, which is basically protein-based, should be avoided in patients with a history of allergy symptoms?
There is no like studies on keto diet per se, but intake of protein in general, like if it's more than 60%, then it would have on animal models and also on the mast cell, human mast cell, an effect of increasing allergic symptoms. But to my knowledge, I'm not aware of the keto diet effect of on allergic diseases.
But high protein does, right?
Yes.
Okay, so next question for Dr. Mona Zaki. So Dr. Mona,
My name is Muna Hafiz.
Mona Hafiz Zaki?
Muna Zaki Hafiz.
Zaki Hafiz, okay. So regarding your topic in GERD, it's a very common disease, right? And at least in family medicine practice. It's really bothering the patient and it's affecting their sleep and their life. So patient usually comes to the clinic worried that it could be something dangerous. It could be more than the GERD, right? So when we can tell the patient, go ahead and do the endoscopy as a first diagnostic test and not to wait or not to take PPI for 8 weeks, like what kind of alarm symptoms that we can?
Some of the alarming symptoms are age. Age is very important. If a patient more than or equal 60 years old of age with the new onset dyspepsia, it is an alarming feature. You will go directly to endoscopy. In case of dysphagia, in case of odynophagia, iron deficiency anemia, okay, especially in patients above 50 years old, in case of unexplained weight loss, in patients with anorexia, in patients with persistent vomiting, and in patients with a family history of first-degree gastric cancer. I think these are the most important alarming features.
Okay, thank you. And we have also a question for Dr. Ghazal Nazif. So in regards to the annual visit, the community usually doesn't know a lot about, regular checkup or what do we do in annual visit. Or if let's say, for example, I'm like 30 years old and I don't have any complaint, why should I visit you? Or like, can you elaborate more in annual visit? What kind of checkup do you do and at what age you do it?
Okay, good question. We offer at our clinic as a family physician some screening tests for the early detection of chronic disease. For example, for hypertension, the U.S. Preventive Services Task Force recommend to start at the age of 18 years and older for the early detection of the hypertension. Also for diabetes from the age of 35, especially in those with individuals with overweight or obesity, we start from the age of the 35 according to the U.S. Preventive Services Task Force,
Okay.
etc.
And when we can do it before 35, is there any cases we do it before 35?
Yeah, like in diabetic patients, some can be screened early if they are having high risk factors.
Okay, thank you. And then I have an interesting question also for Dr. Faiza. Is it really heavy carb diet is the heavy carb diet play a role in increasing the general inflammatory state of the body while the plant and protein based are not?
Can you repeat it? I can hear it as echo.
Sorry?
Can you repeat the question? I can hear it as echo rather than.
Oh,
yeah, it's
okay.
not that clear.
Yeah,
Sorry.
So the question is the heavy carb diet play a role in increasing general inflammatory state of the body and the plant and protein based are not?
Yes, true.
Yeah, so
Like high carbohydrate diets has like a negative effect on and like inflammatory status of the body, while the plant-based or nutritionally balanced diet is protective. Regarding the effect of carbohydrates, it's sometimes like you can see that it interfere with the sort of like digestion, interfere with the fermentation induced by the gut microbiome. Also, that interfere with the anti-inflammatory effect of these gut micronutrients, especially that the carbohydrate is usually fermented in the gut and induce the imbalance of the gut microbiome.
okay. All right, and we have one last question. I don't know if I have time to do it. Again, for Dr. Faiza. Dr. Faiza, they need a summary of the diet that should be avoided in patients with atopy, but I'm not sure if we have time to discuss the whole, summary of which diet should be avoided in patients with atopy.
Yes, in general, the diet you should avoid or at least reduce the content of high protein diet. You should also avoid high fat, the saturated fatty acids, the medium chain fatty acid, and also the like, as we can see, like omega-6 fatty acid. This is usually the theme that you will have to avoid if you have atopic diseases. You have, on the other hand, to increase the content of iron, vitamins like A, D, and C, as well as increase the supplementation of gut microbiota, either through like certain food that is rich, like kimchi, for example, or having the supplementation of probiotics. Also, a high fiber diet is having a protective role against allergic diseases because of their metabolites, mainly butyrate and propionate. There's also reducing the Th2 cytokine.
Okay, really good to know. I enjoy the discussion as much as the audience, but for the purpose of the time, I think we have to end it here. Thank you so much for your presentation. It's credible. I think it's honor time. Honoring time. Thank you very much.
Thank you very much.
خلاص نمشي.
Great thanks to our speakers for first session today. Dr. Masleh Al-Rashidi, would you mind to join us on the stage for honoring? Dr. Ghazal Al-Anizi, thank you so much. Dr. Muna Zaki, thank you. Dr. Faiza Al-Ghanmi, our great thanks. Our amazing moderator, Dr. Amal Al-Shammari, thank you so much.
Assalamu alaikum. معكم Amsha Shammari. Welcome again. For today, I have a great quote. Theodore Roosevelt said, "Old age, like everything else, to make success of it, you should be start early." الشيخوخة هي كباقي الأشياء، لكي تنجح بها عليك أن تبدأ من الصفر. Mark Twain said, wrinkles should be merely indicate where smiles have been. التجاعيد هي فقط تشير إلى أين كانت الابتسامة. So now, could I ask your attention for our next presentation about health and nutrition for geriatric. Our next moderator, Dr. Rakana Al-Utaibi. Dr. Rakana Al-Utaibi, Director of Medical Director in King Salman Specialist Hospital, Consultant General Surgeon. Welcome.
Assalamu alaikum. Good morning, everyone. The previous presenter gave us a great quotes. I believe that the age group that we're going to talk about now, we owe that age group a lot. For myself, I'm not standing here if it wasn't from my mom and dad and my grandparents. The focus that we should have for this age group is really drastic because their role in our life is still continuous. even if we reach the maximum level of success. So our lectures today is focused on geriatric age group, or the senior citizens in our community. The first speaker, Dr. Rana Hisham. She's a family medicine consultant, also focused on geriatric medicine. She is from King Fahd Medical City in Riyadh. Welcome, Dr. Rana.
Assalamu alaikum wa rahmatullah. Good morning, welcome everyone. We will start today to talk about geriatric diet, the nutrition for seniors, how to eat well to age well. I put this picture to show that there are many things that will support healthy aging. Food, fitness, social connections, resilience, many things, but today we are going to focus on nutrition. So why is good nutrition so important as we are aging? One thing that's very important that a lot of people aren't aware of is that our nutrient needs actually do change as we age. And certain things like protein, fiber, calcium, vitamin D, vitamin B12 are nutrients that are actually need more as we are aging. More people aren't aware of that. I'm going to give some tips today to how make sure that we are getting those nutrients as we are aging. There are a lot of concerns coming from our seniors. Do my nutrition needs change as I age? Do I need more protein? What I can eat to build stronger bones and prevent falls? And there are a lot of challenges. Sometimes we are on a lot of different medications and they are interact with our nutrient needs. There are issues with bowel health, constipation, and dehydration sometimes is an issue. Also, living alone, cooking for one, if we have limited income, really are challenges for eating well. But we have good news. We do know from the evidence that what we are eating makes a difference to our health. It can improve not only our physical health, but also our mental health. It can increase energy levels. It can keep our bones and muscles strong to prevent falls. And the literature shows that what we eat can improve our blood pressure, blood sugar, and it can reduce risk of our heart disease. There is actually even more evidence showing that what we can eat, we have a profound effect on both preventing and managing depression and memory changes. For those of us that have seniors in our lives, we may be noticing some things as well. Perhaps they are not eating as much as they used to. Their appetite is lower than before. Perhaps they are easily full and they can't finish the plate that they normally would eat. They might be finding that fatigue is an issue, so they are skipping meals sometimes. I have a lot of people who will say, well, you know, it's not really worth turning the oven on just for one person. So they are going for processed foods or prepared foods, which may or may not have all the nutrients we need in the optimal balance. In addition, there are challenges that start to happen sometimes with muscles. As swallowing takes over 100 muscles to swallow safely, sometimes people start to cough, choke while they are eating or drinking fluids. Also, we are usually noticing changes maybe in things like having new dentures, so suddenly they start eating a lot of soft foods. Also, always constipation is an issue with aging. Health problems can often get a bit complicated as we get older. We see a lot of people with diabetes, but also the person with diabetes may have hypertension, high blood pressure, high cholesterol, irritable bowel. So it can get very complicated for the person to try to figure out what do I actually eat when I have these different conditions. As well, we've mentioned medication effects. There is a lot of medication effects, and they can affect many of the nutrients we need. For example, again, in diabetes, we have a medication, metformin, and it's very essential in diabetes. This medication can actually lower appetite sometimes, and it also can affect vitamin B12, as well as some of the fluid pills like diuretics we are using for hypertension or heart failure. People are taking, it can lead to dehydration. It's really important that we are aware of these medications and looking for it. So when we start to look at senior health, the research is showing that there is some concern that 1 out of 3 older adults over the age of 65 are at high nutritional risk. And that can lead to complications and falls and hospitalizations. When we start to look at whom it more has risk, it tends to be more common in women living with depression, grief, or loneliness, if they are living alone with limited social support, if they have low income or have poor oral health. Also, medications always are a problem. If they are on 5 or more medications, they are at more risk of nutritional problems. And the research actually shows that if someone is malnourished, there are a much higher risk of falling, and that's a big concern for our seniors. They are always concerned about falling, and so malnourished seniors are 73% more likely to fall than well-nourished seniors. Also, if we go to hospitalization, in fact, a recent study showed that 1 out of every 2 adults on admission to hospitals are being flagged as malnourished. And what happens is those tend to stay longer and tend to worsen during their stay. There is higher mortality rates as well, especially if the malnourished, once they are discharged, they have higher rate to readmission after 30 days, especially if malnutrition was not addressed while in the admission. And when we look at the impact not only on the individual and the quality of life of living with malnutrition, but also on healthcare and healthcare money, it accounts for a significant amount of $2 billion out of $25 billion hospital costs in Canada. So we have mentioned points about some of the challenges we see in seniors. So let's talk about how we can start eating well. This picture illustrates the types of foods we need in our diet. As you can see from here, we really want to emphasize plenty of fruits, vegetables, taking about half of the plate, and then a quarter of the meal being protein. Protein includes things like fish, meat, eggs, beans, nuts, soy products. And we are going to talk a little bit more about the importance of protein because it's very critical in seniors. Also, in senior population, we emphasize choosing whole grain foods as part of the meal. And also a lot of different kind of trendy styles of eating, but we want to emphasize trying to get good variety of all the key foods that provide benefits to our diet. So on this slide, we'll just talk a little bit about some of those things. Diets that are rich in healthy food support healthy body. So we are not with restriction in seniors. We are more with emphasizing the things that maybe we are lacking. So we want to make sure that they are getting lots of fruits, vegetables, nuts, seeds. They want to have, need to offer lots of healthy fats, fibers. Whole grains are very important. Fish, seafood provide lots of great healthy brain fats. We also want to be including calcium-rich foods such as yogurt, cheese, milk, and then healthy fats such as olive oil. So you may be looking at a list of all of these different foods and say, how can I have all these changes? Well, we always advise people to start small. Change is not easy for anyone. Even if we can think of one thing that we can change weekly, it will improve our eating. It's talking all of small steps to get to our longer term goal that's important. Adding more fruits, vegetables, whole grains, adding more fish, trying to make sure you get enough protein, feel like you have to do it all at once is very critical. So just pick one thing this week to make change, and then once you've accomplished that, add another small change. So, do your protein needs go up as we are aging? Well, we think that if we are getting older, we don't have as much energy, so we probably don't need as much. But the truth is, our protein needs actually tend to increase as we get older. And it's very challenging because as our appetite going down with aging, we are filling up faster. It can be tougher to meet those protein needs. So typically, we encourage people to try and have protein at every single meal because protein is quite filling. Most people are really good about trying to get protein in lunchtime by having some chicken, beef, fish. But a lot of people forget about the importance of protein at other meals. It's important to try to have protein with our dinner and with our breakfast. Protein is found in nuts, eggs, fish, chicken, and dairy products. So for example, adding beans at lunch or adding peanut butter, Greek yogurt to breakfast is an easy way to add extra protein into diet. But we are looking at roughly 25 grams per meal to get enough protein, and protein is important for our muscles. If we are not getting enough protein in our diet, sometimes that can be a contributing factor to our fatigue. And also when we eat does matter. Food is a fuel, and we don't want us to run out of it. We need to avoid skipping meals, forgetting to eat, or going long period without eating, and that's very important, especially in seniors. Because these affect particularly things like low blood sugar, hypoglycemia, and the trouble is, as we are getting older, sometimes our sensitivity to feeling hypoglycemia can go down. Some of the common symptoms that we might experience if we have low blood sugar, it will be headache, sweating, dizziness, palpitation, anxiousness. So we encourage people that suffer from things like that, especially anxiety, to have regular meals through the day, because when our blood sugars are fluctuating up and down because we've been skipping meals often, that can make those symptoms feel worse. And think about that protein needs, 25 gram protein every meal. If we are not having, or if we are having only 1 or 2 meals, that means that we need to have 75 gram per the meal, and it's impossible. Also, one of the most common questions we have getting over the past years, especially after Corona, that how can I support my immune system? In terms of optimizing systems, we want to a healthy diet with healthy foods rich in nutrients. We want to try to avoid ultra-processed foods because they tend to come with very few nutrients and maybe giving us excess sodium and saturated fats and causing more inflammation. And within immunity, what we are looking at is trying to reduce inflammation. Drinking water daily is important as well for dehydration. Getting adequate sleep and also managing stress is very important. So these all are basics for enhancing our immune system. So the hydration piece is actually really important, and I see a lot where people are not drinking enough fluid in the day, and they just don't realize that dehydration can really impact our health, especially our blood pressure, our mood and concentration, our immune function. A lot of people are waiting until they feel like they are thirsty, but they haven't been drinking enough fluids for a very long time. The sense of thirst may not actually be there even though they are dehydrated. So this is a really important point, is that we get we need to get fluid throughout the day, not just at the end of the day, especially also for our seniors, because that does tend to keep us at night running to the bathroom, and it's a risk for falls. And we want to make sure that we are drinking is what we are drinking is not causing health problems or affecting us in a negative way. So we need to avoid excessive free sugars, caffeine, and to encourage water. Other nutrients that are really important for immunity, and it's interesting when I started to look into this, I hadn't realized that when we are aging, we actually make less immune cells. The research is showing that really to maximize making these immune cells to fight off infection, we need to make sure the key nutrients are there, especially some of the nutrients that help to manage inflammation. Some of these are protein, carbohydrates, fatty acids, vitamins, minerals, and fluids. Omega-3 also is one of these fats. So let's talk a little bit more about this. Omega-3, it's a healthy fat, very important for our health. Many of us heard about this regarding cholesterol, reducing risk of heart attack and stroke, but also they are very important of reducing inflammation. And so we are trying to encourage people to include the foods that have omega-3. We can find omega-3 in fish, salmon, sardines, also in plant sources, for example, walnuts, flaxseed, chia seeds. Vitamin D is such also an important vitamin. Here's a question: is it true or false that vitamin D is a common deficiency in the world? Yeah, it's true. Taking vitamin D supplement can help prevent falls and support a healthy immune system? Sure. Well, that's actually very true. We have a high prevalence of deficiency of vitamin D in Saudi Arabia, and it's associated with falling and query with depression, as well as mental health and poor immune function. So we really need to encourage people to be aware of where can you get it in our food, and it's pretty limited, like in fish and milk. So for many people, it's hard to get enough from food sources. We do get it from sun, but we are not really exposed to a lot of sun, or the surface area of our bodies are not exposed. For that reason, we absolutely need to supplement with vitamin D3, about 1,600 to 800 units per day, 2,000 international units a day, and sometimes people will need a bit more. And from the researchers, we encourage not to give the weekly high dose for seniors because it increases the fall risk. We prefer the daily doses. Vitamin B12. Here's another vitamin that we want everyone to be aware of, because it's also turning out to be a very common deficiency. And they are estimating about a third of adults over the age of 50 may be low in vitamin B12. There's many risk factors for this. To be vegetarian or on vegan diet, some medication pills, the same example before, metformin, it can decrease vitamin B12 levels. Also, aging alone seems to affect vitamin B12. Also, gastric conditions like heartburn, acidity, reflux, as well as people have conditions like celiac disease or Crohn's disease, or after bariatric surgeries. Here's a list of the symptoms to watch for low vitamin B12. Sometimes it's only having the low energy, or we can have numbness, tingling in the fingers or toes, but it actually can be linked with even more serious conditions like dementia and poor memory. True deficiency is when it gets under about 149, but for seniors, the research shows that we really need to keep their serum vitamin B12 levels between 250 to 600 on the range. Magnesium is a very important mineral for many things. It makes many cofactors in the body, and it's important for sleep and the production of brain neurotransmitters like serotonin and dopamine. I were always thought it was never that common, but the research is starting to show that it may be more common than we think, and that could be due to low intake of foods that have magnesium. Also, again, the medication interaction can have effect. For example, hydrochlorothiazide can impact not only potassium, but also it can affect the magnesium. So magnesium has an important role in many functions in the body, from bone to muscle, to many cofactors for helping us use our energy properly. And we really need to make sure that people are aware of magnesium-rich foods like pumpkin seeds, quinoa, nuts, and seeds. This is just a summary page that sort of highlights some of the key vitamins and minerals and healthy fats that we really want to be aware of when it comes to senior health. We've talked about a number of important things to be focusing on, but what you eat is not the only thing that's important. Also, thinking about how we are eating. Taking time to eat, making sure that we are eating slowly, thoughtfully is very important. We need to eat without distractions by TV, mobile, or anything. We encourage people to have regular scheduled time to sit down and eat meals and enjoy them. And we want to be aware of why we are eating. Sometimes we are eating not only we are hungry. Sometimes we are eating because we are bored or feeling lonely. That's more for seniors. Or eating because we are angry, anxious. Sometimes just only because we are happy. The feeling doesn't always have to be negative. Sometimes it's because we are excited. And there's something to be said about bringing a social piece into food, especially for seniors. Cooking and eating together, enjoying meals with family and friends, all are important for the seniors. Also, it's important for the senior to feel comfortable in the kitchen, making their own food. Also, we need to make sure that we are finding ways to stay connected. So not everyone has the benefit of having other people living in their household, but they can use the technology now. We would definitely encourage people to do things like Zoom dinners sometimes, where they'll be connecting with family and having their own meal at home. They are still safe to be at home, but connecting with friends and family by the technology.
Sorry, Dr. Rana.
Okay. على الوقت. Thank you.
Thank you, Dr. Rana, for this very informative presentation. Before I start with the next speaker, I would like to remind everyone that we have QR codes for questions and evaluation for this session. Our next speaker is Dr. Abdulaziz Al-Jahani. Dr. Abdulaziz Al-Jahani is a board-certified physician, family medicine. He also got his residency from British Columbia in Vancouver in pain management and palliative care. Please welcome Dr. Abdulaziz Al-Jahani.
Good morning, guys. I'm so proud to be here for the second time in the حائل International Lifestyle Medicine Conference. But I belong a group which is constitutes a majority of among the world, which is shorter people. So I cannot stand behind the podium because you will see only my head. So I like to move everywhere on the stage so everybody can see me. Guys, I have a question for you before I start. His profession is mandate him to care for patients with uncured conditions? Raise hands. مين اللي تخصصه يخليه كيرنج لمرضى غير قابلين للعلاج؟ ما في علاج يقدر يشيل المرض. مين؟ اوكي راكان. اوكي اكسلنت. انا شايف كثير كانوا فاميلي فيزيشنز. فالدايابيتس is not a cured condition. Hypertension essential is not cured. So there is a lot of conditions that are uncured. Okay, who's from the audience has a lover person, has a chronic condition that is not cured? مين عنده إنسان عزيز عليه جدا, uncle, cousin, parents, عنده disease غير قابل للعلاج؟ Okay, great. So I hope you will get benefits from this presentation, because it is about a nutritional support at the end of life. Okay, so that's me. I have issues. So how it's work? Okay, anyone from the audience is not understanding Arabic language? Okay. So I would like to excuse you, because sometimes I am using some Arabic terms to let the other group to understand what I mean. Okay. It should be to this side. Okay. So how we can move this one? Yes. It's to go back. No. No, this is forward. No, go back. No, you're not.
هذا اللي كنت عشان تعمله في العربي يمشوا بالعكس
كده. So excuse me. It is not similar.
We have changed the settings.
Okay.
Let's check here. Okay.
Here.
Here. It's okay. Forward.
This one.
Yes. Okay.
This is the objectives. Okay. So this is my objectives for the presentation. So I hope all of you, by the end of this small presentation, you will be able to recognize the concepts of vulnerability and categorize the key issues, please, the key issues in end-of-life nutrition for your lovers and for your patients, and how you apply the best practice in nutritional care at end of life as a profession or as a caregiver, okay? So as introduction, there are medical conditions that is not cured. If you will ask the cardiologist, for example, he will tell you that heart failure is not a cured disease. So by the end of the day, he will need some care not related to the medical treatments. Okay? So we defined it in palliative medicine as a vulnerability. It is a human condition defined by limit of experience of medical care. So you are unable to give a treatment, medical treatments, manufactured drugs to help the patients to be improved. So, so you need some actions not only to cure the disease, but also to help the patients to have a good quality of life, to have a good psychosocial concepts and spiritual well-being. Okay? So let's to think together, and I would like you to share your opinion. What do you think, guys? Is nutrition and hydration at the end of life is a basic care or treatment? What I mean by basic care, that you keep IV fluids and nutritional support to the patients just to maintain the homeostasis, the circulation with the patients. Or it is a treatment that in some way it can change the pathogenesis of the disease when you are giving him a nutrition. What do you think? He think it is a basic care, I cannot suspend it, and I should continue to give IV fluid to the patients? Raise hands. Okay, okay, great. Who's think no? As an expert's matter, I should give the nutrition as a treatment. When the patient is not needed, I should stop it. Raise hands. Okay, great. This is really a controversial area among the world, especially at the end of life. So in the existing literature, they define the people to two groups. Group number one, they think it is a basic care, having an inherent nature, so I cannot suspend it. I cannot stop it. I will let it until the patients die. Okay? But the other group, no. They think it is a medical treatment and it should be provided in a waivable process when the patient needs. Okay? Based on the medical condition. Okay, but how we can proceed as an experts master and as a professions in our specialty? How we can proceed if there is a controversy? Okay, given this controversy about the use of nutrition and hydration at the end of the life, so each case should be managed individually. Because what's suitable for a patient with a lung cancer is not suitable for a patient with COPD. Okay? So when we are caring for the patients, we should take each case individual and we try to manage him based on that. And keep in mind, you will be at the end of life, you have a third party with you in the care. That is the family. So the caregiver will think if you are stop the nutritional support that you are abandonment of the patients. انت بتتخلى عنه. انت ما بتعطيه nutritional support. You are not giving him something that's help him. And I have a lot of examples about how the people, even the health professions, they are, I know one of my colleagues, he is a pulmonologist, and while his father having lung cancer, on the last day of his life, he asked me to start BiPAP to keep him alive. So you should solve this issue with the family by a very nice strategy. I will tell you how. So changing needs. Okay, so please, when you have a patient, you know as an expert matter that no treatment, and he will reach to the stage that he will be at the end stage that no care can be provided. So start nutritional support and the discussion with the family, with the patients, with the expert matters with you, because you are not working alone, early as soon as possible. Okay? So thinking as an expert matter, because you don't like to reach to the ends and accidentally, dramatically, the patient's decline and the family will come to you. Doctor, we are with you since 10 years following, and you don't tell us that we will reach to this stage. So please, giving advice early as soon as possible about nourishing meals and drinks, snacks, according to the patient's feel at different times. Don't bring him to the OBD just talking about the medications. So talk about nutritional support. And the use of, keep it in mind that the evidence at the end of the life is not supporting to give nutritions, hydrations parenterally, please, okay? Because it increases the risk. It will be harmful for the patients. He will be at risk of infection. He will be at risk for shortness of breath, between edema, a lot of issues, okay? So what is the key issues in end-of-life nutrition that I should consider as a healthcare practitioner when we are dealing with the patients with incurable disease? First, loss of appetite and the anorexia is a major issue. Is a major issue that anyone have a chronic disease, even diabetes, he will have anorexia, okay? Why? Even us, as a healthcare practitioner, when you have just a small clinical medical problem, you don't eat as usual, okay? So loss of appetite, most of the time caused by anxiety, because it is not easy for the patients to tell him, oh, unfortunately, you have MS, multiple sclerosis, or you have a colorectal cancer. It is not easy. That will develop depression and anxiety to the patients, and you should consider that. And sometimes the nature of the illness is related to the loss of appetite. So he unable to eat. Don't enforce. Because someone will with GERD, what was mentioned by Dr. Mona, or celiac disease, he has some restrictions. This is the nature of the disease that enable him to eat as a healthy people. So medication, please almost always review medications, because it can cause loss of appetite, okay? So the medications, especially the pain medications from the third level of pain management. And don't worry, you can use some appetite stimulants and it can help. And the best example, for example, steroids. Steroids, it can help patients with loss of appetite about how they can care. Managing the symptoms is very important. So first, take in consideration loss of appetite, identify the cause, treat it. This is one of the issues. Second issue, manage symptoms related to the loss of appetite, decreased nutritional support at the end of life. First, a dry mouth. Frequent mouth rinsing is very important for the elderly. If you have a bedridden patient or relative, please keep in care of the mouth. It should be not dry. Second, taste change. People with the chronic disease, they don't taste the food as a healthy people. No, it needs, usually I advise my patients to utilize tart foods like lemon, orange, That's helped them to change the taste. And sometimes providing the foods at different temperature and texture, it can help. Okay? Swallowing problem, usually I'm consulting the speech pathologist to help me in that issue, especially if the patient has something in upper GI tract. So I let them to suggest. And don't forget thickened drink. We usually prescribe it to the patients. If some patients is unable or is bedridden or have a chronic conditions that not enabling him to swallow, try the thickening fluids. Then nausea and vomiting. Dr. Rana before me, she mentions that the meals for one with the chronic conditions at the end of life, it should be small and more frequent. Small and more frequent, and sometimes we are using the medications to help him to overcome the nausea and vomiting. And we have a huge list of medication that it can help. Okay? So constipation, very important that any patients at end of life stage should be on laxative, in addition to increase the fluid intake. Optimizing in nutrition, very important. البروتين is crucial. البروتين يا جماعة في واحد end of the stage life, البروتين is crucial. It should be لأنه بيصير عندهم they have muscle wasting والبروتين يساعدهم كثير to build المصل فما يضعف. Okay? So as mentioned by Dr. Rana before me, they needs duplicate. It needs healthy people. If the healthy people just needs 0.8 gram per kg, patients at end of life stage, he needs double, 1.4 to 2 gram per kilogram for those suffering from advanced disease. Again, the quality of food is very important. Okay, protein is crucial, but keep the different foods at different meals. So meat, chicken, and fish is a very good source for the protein, but also dairy foods like yogurt, cheese, and alternatives such as soya products, it can help those kinds of patients. Breads, cereals, whole grains, rice, pasta, والvegetables والfruits. Omega-3 fatty acids, as mentioned by Dr. Rana before me, for the seniors, it's very good. For the people with chronic and end-of-stage disease, it is a mandate. So usually I prescribe it for them. I give them, it is available in the market as a tablet, so we will give them 2 to 4 tablets per day, omega-3 500 milligram capsules, or the fish oil liquids, and we will give it the caregiver to give him 2 teaspoons daily. This is a meal plan for a patient with chronic conditions or bedridden. Usually we give it to the family and we explain very well to them how they can, and you can see that the protein is a lot. The best practice of nutritional care at the end of life, but based on the evidence from the American Association of the Palliative Medicine and even from the Royal College for Physician and Surgeon of Canada, patients continue, he can continue to receive the foods, no issues. And please, conversation and education for the caregivers and for the patients is mandate. We should educate them. And hydration intervention should be limited at the end stage of life. It will not help. Okay? Frequent monitoring is crucial in the care. So to ensure that interventions meeting the needs of the patients and the family. Please, there is no difference in the survival rates between someone I keep him on IV fluid hydration and someone is not. And you will you will face a lot of questions during the family meetings of the patients, or when you are discuss the plan. So one of the questions is, reduced fluid intake can affect the kidney? No. Okay? Not compromise to the kidney function. A crucial belief, لازم keep it in mind, because a cultural difference while you are providing the care is very important. A patient's status and individual needs and wishes can change quickly during the care. Keep it in mind. In summary, I can show them the video. I have 1 minute video from my colleague David Ho. He's in Houston, and we are together at Canada while we are doing the fellowship. So we can show them the video, guys. Okay. So it is just 1 minute. He will give you a sum up to what I mentioned in the since the beginning. Yeah.
Topic with a lot of debate over the past few years is when patients are approaching their final days in their lives, whether they would benefit from receiving hydration or nutrition, given that many of them by that time won't be able to drink or eat on their own very well. This is also a very important issue, not just for patients, but also for family members. So we thought that it's very important, based on the literature, to look at the potential benefits for hydration versus the potential side effects. And there have been some randomized control trials recently conducted by our group looking at whether hydration can help people in different ways. Recently, we have been looking at some of the physical signs of impending death in our group. And what we found is that there are some telltale signs that if we pay attention at the bedside to look at the patient, we can see that they may be entering their final days in life with high degree of confidence. So some of these may include, death rattle, respiration with mandibular movement, drooping of nasolabial fold, as well as pulses of radial artery. And if the doctors can see these signs, then they feel much more confident that the patient will die in the next 3 days. However, the absence of these signs cannot completely rule out impending death. I think given that with limited side effects.
Thank you so much, guys. And this is the references and resources if you would like to read more about this interesting topic. Thank you. Thank you so much.
Thank you, Dr. Abdulaziz. I'm sorry that we had to stop you at the end, or at least interfere with your presentation, but we have a very tight schedule. Need to remind you that we have a QR code for questions for the discussion panel, and we have a feedback QR code for the session number 2. Now, for the next speaker, we have Dr. Kelly Freeman, virtually. She is the Director of Workforce Development of American College of Lifestyle Medicine. She's going to join us virtually through the screens. So please welcome Dr. Kelly Freeman. Thank you.
Hello, everyone. My name is Kelly Freeman. I'm the Director of Workforce Development for the American College of Lifestyle Medicine, and I am honored to be here with all of you today to discuss lifestyle medicine for the older adult. My background happens to be geriatrics, and this is something that I'm extremely interested in and have seen incredible progress over the last few years, so it's exciting to share. The objectives for over the next 20 minutes or so will be to discuss how a comprehensive geriatrics and lifestyle medicine assessment can help detect your older adults' needs and then list the drivers of health and the main causes of death that are exclusive to those older adults. And then finally, I'll share some strategies to incorporate lifestyle medicine into the clinical care for older adults for the treatment of multiple types of geriatric syndromes. Before we do all that though, let's just watch a short video. This is from the Canadian Heart and Stroke Foundation. Enjoy. Powerful video, huh? So that is makehealthlast.ca from Canada. And then something that we know about health behaviors is that these can so impact quality of life, quantity of life. And one example of this that I can share is through something called the blue zones. And these are places around the world where people just tend to live very healthy, long lives. And so certainly this goes hand in hand with clinical aspects of health behavior changes. And so now let's talk a little bit about those. Let's start with what causes early death in older adults in particular. Those include sedentary behaviors, poor dietary habits, social isolation, risky substance use, and polypharmacy. And one thing to keep in mind is that a lot of this is not the patient's fault. There are many contributing factors to why they may be sedentary, including possibly an injury at some point, chronic pain, arthritis, etc. As far as poor dietary habits, they perhaps maybe are not able to afford the food that they need to eat or don't know how to prepare it. Social isolation can grow as people grow older and perhaps their loved ones have passed away or they're far away from family members. As far as risky substance use, we know that this can happen in older adults, and not only with, let's say, street drugs, nicotine, but then also sometimes with medications that can be addictive, sleepers, pain medication. And then we also have patients who are on a large number of medications. So polypharmacy means 5 or more medications, or less than that if those medications really are not indicated or are causing some major side effects. So all of these are contributing factors to early death in our older adults. And so just first things first, as lifestyle medicine physicians and clinicians, we can really address some of these issues. Now, there are also a number of drivers of health, and these are listed here. You probably have heard of social determinants of health or social drivers of health, and this is basically our experience around us, how we live, work, eat, and play, which can be incredibly influential on our overall health. But then there's also some biological factors. So there can be some predispositions to disease due to some genetics. However, something that we've learned over the last 5-10 years is that lifestyle interventions can be even more impactful when people do have these genetic predispositions, such as for breast cancer, colon cancer, heart disease, and even Alzheimer's. Political drivers of health include anything that is related to policy. So some policies can be helpful for health, including perhaps universal health care. And then there may be other policies that can drive people towards poorer health. And then as far as commercial drivers of health, with that, we're talking about economic operators that influence behaviors, such as commercials, marketing, and this again can also be positive or negative depending on what the marketing is. All right, so when we are seeing someone in the clinical setting that is elderly, older, having the 5 M's in mind can come in very handy. So the 5 M's are mind, mobility, medications, multi-complexity, and what matters most. And so when we're looking at just a complexity of diagnoses and medications and all that, it just kind of helps us to focus a bit. So as far as the mind goes, is there depression, cognitive decline, anxiety? As far as mobility, what is their level of mobility? Can they do what they need to in a given day? Medications, what medications are they on? Multi-complexity goes into all these chronic diseases, especially geriatric syndromes, which we'll get to in a later slide. And then finally, matters most is what matters to the patient? What do they want? All right, so lifestyle medicine goes hand in hand with the 5 M's and actually can boost the level of what we can do to really impact their lives and quality of life, quantity of life. So instead of just looking for disease with the mind, cognitive decline, etc., we look at how we can make the mind as healthy as possible. How can we optimize social interactions and coping mechanisms? And then with mobility, how can we get them to the highest level of physical activity that they're able to tolerate? As far as medications go, lifestyle medicine gives us the opportunity to utilize food as medicine alongside or instead of medications. And in some cases, when these lifestyle interventions stick and are impactful, we may even be able to de-escalate or de-prescribe some of the medications. And then as far as multi-complexity, lifestyle interventions can be the foundation of so many geriatric syndromes. And then finally, as far as what matters most, we want to ask our patient that every time. What matters to them? What gets them up in the morning? And also, what lifestyle interventions are they willing to change that may impact their health? So would they want to be focused first on sleep or nutrition or whatever they're most interested is probably going to be the most impactful. All right, so next let's talk about detecting older adults' needs through a comprehensive geriatrics and lifestyle medicine assessment. Now, as usual, we start with our health history and physical assessment, knowing that it is going to be complex. People who have lived 70, 80, 90 years have a lot of history and most likely more chronic diseases than those who are younger. This assessment is also going to take a lot more time than with a younger person. We're going to have to talk slowly, maybe a little louder, and our movements are just going to have to be a little more purposeful to be able to not tire the older adult that we're working with. So certainly this takes a little different approach. Now, we want to know their functional status, and that includes how they're doing as far as physical, psychological, social, spiritual, and intellectual activities, and if their needs of daily living are getting met. Our occupational and physical therapy colleagues are wonderful at doing functional status. This is for these patients. They're also wonderful in helping us with home safety. So they can help us determine whether our patients are living somewhere that's conducive of implementing lifestyle changes. And if not, then what level of care is necessary? What do our patients need? All right, I already mentioned the 5 M's, but certainly as we're doing all this, we want to keep those in mind. And then what we're looking for are geriatric syndromes. And the reason these are called syndromes is because they're so multifaceted. There's probably multiple reasons that they happened, and also it's going to take a multifaceted approach in order to improve these syndromes. So they include frailty or failure to thrive, incontinence, constipation, cognitive issues, falls, bone fractures, pressure ulcers, and chronic pain. All quite complex and challenging, and also all have the foundation, have lifestyle interventions as the foundation for them. So, and finally, a lifestyle assessment. And I just want to give you a quick example of why a lifestyle assessment is so important. And this was back many years ago. I walked into a patient's room. This was an outpatient clinic. He was on more medications than I'd ever seen a patient on. He looked pretty sick. He was in his 70s. And for whatever reason, the first question I asked him was, "Hey, what did you have for breakfast and lunch today?" And his answer didn't surprise me that much, or at least his first answer. His first answer was, "I had donuts for breakfast and I had pizza for lunch." So I asked him a follow-up question, and that follow-up question is, "Well, are those your favorite foods?" And he started crying. And after a little bit of time went by, he shared with me that he hadn't been able to drive for a long time. He could not go to the store. And the only food that he was receiving from the significant other that was bringing him food was donuts and pizza. This had gone on for months. So this kind of thing can happen. And without asking an assessment question related to one of our most important pillars, well, they're all super important, but one of the pillars, I would have never known what he needed. What he really needed was some food, and some good, healthy food, some nutritious food. So we arranged that, and we can do that with lots more older adults as well. So a couple examples of lifestyle assessments. One is through Loma Linda University and the American College of Lifestyle Medicine. There is a short form and a long form that you can download from the ACLM website, lifestylemedicine.org. And then also the American Association of Family Physicians has a version, and there are also a few other great versions as well. So many to choose from. And also, many health systems are starting to move lifestyle assessments into their electronic health record. So if that's not something that you're currently seeing where you are practicing, that might be a great opportunity for you as well. All right, and finally, 3 really important questions to answer and address when you're doing that assessment of the older adult. And that is, how well can they see? How well can they hear, and how well can they chew? And, fairly often there are deficits with all 3 of these. So if they can't see well, can we get them better glasses? Do they need their cataracts removed? As far as hearing, is there wax in their ears? Do they need hearing aids or some kind of an amplification device? And then finally, as far as chewing, if we can't get them if they're not able to chew well, then it makes it really hard for them to get the nutrition that they need from the types of foods we would love for them to eat. And so we may have to think of modifying the foods, either cooking them more so they're softer, or blending, so like blended soups, blended smoothies. So really, really impactful, important questions to ask our older adults. And what I've experienced over and over again is that older adults do want to know what's best for their health. That's why they're seeing you. You are the expert. So you may be needing to prescribe a medication, but you may also, through a lifestyle medicine or lifestyle assessment, find that they would benefit from some lifestyle interventions that are doable. Now, I wanted to share this resource. This is from Susan Friedman, Dr. Susan Friedman and her team, and it lists primary, secondary, and tertiary prevention of chronic disease through lifestyle interventions. So this is just a great tool for you to utilize. And also keep in mind that these targeted therapeutic lifestyle interventions can improve some aspects of health within days to weeks. It does not sometimes take very long for improvements to show. So that's really exciting and really impactful. And I am going to give you this time just a personal example. My mom is now 83. When she was 70-something, early 70s, she was diagnosed with hypertension. She had on and off taken medications, but found them to be problematic as far as adverse reactions. And so my sister and I were with her one day. and she had a transient ischemic attack. And it was witnessed. We saw her stop talking. She was confused. And fortunately, very quickly, she came back. And we were both extremely grateful. Got her to the emergency room where her blood pressure was very high, like 180s over 120s, 130s. And so she went back on a blood pressure medication for a while, although then she had the same side effects and wanted to know if she could do more health related. And so I guided her along with her physician to start exercising more and going out to eat less and eating beets and spinach and squash and all those good foods that can help lower the blood pressure, alongside hibiscus tea and green tea that was decaffeinated. And it took probably somewhere between 6 and 8 months, but eventually her blood pressure leveled off to what you see on the screen here. So normally it's in the 120s over 60s, and then sometimes just a little higher than that, but that tends to be the range. So this is just one small example of how targeted lifestyle interventions can really optimize blood pressure for older adults, or for anyone for that matter. And we also know just how incredibly important a healthy blood pressure is for anyone of any age. And thankfully, my mother is now 83 and has not had another TIA as far as we know. And she's actually seems quite a bit healthier than she was 3 years ago. All right, so finally, I'm going to very quickly talk about some strategies to incorporate lifestyle medicine into the clinical care of older adults. And so just going by the pillars here, there is physical activity. There's some examples here. I do have a list of resources at the end of the screen in case you want to explore some websites related to all of this. Just a couple shout outs here. One is for aquatic programs. So any type of water activity may be especially beneficial for your older adults with any kind of joint pain or chronic pain. And then exercise snacks can be very fun and doable for older adults. And there are lots of videos about exercise snacks. So just short bouts of fun activity. My colleagues have already shared so much about nutrition and dietary pattern, so I'm going to skip by that one. And then as far as healthy coping mechanisms, you see a list here of potential opportunities. And I do want to give a shout out to an entity called the LIFT Project. It's the LIFT Project Global, and it is a series of activities or of modules that have activities and videos, and it's just incredibly inspiring and is evidence-based positive psychology to help lift the mood. And you can utilize those different modules either with individual patients on their own, or in a clinical setting, in a group setting, or even in the community. So lots of opportunities there. As far as quality sleep, when we talk about sleep hygiene, that is what we can do to make sleep better. So whether it's a darker room, a colder room, a quieter room, whatever we can do to encourage that good sleep. And then we also want to make sure that our patients are avoiding any of those substances that won't help them sleep. There is cognitive behavioral therapy for insomnia, either virtually or in person, that can be helpful. And finally, when we're doing our assessment, if we do find that the patient may have obstructive sleep apnea, we certainly want to address that. And then as far as social interactions go, I'm going to say something you've already heard before, and you can probably even guess it, but let's get their vision checked, let's get their hearing checked, because both of those can be very impactful in their quality of social interactions. And then finally, as far as risky substance exposure, be extra cautious with any type of over-the-counters with these older adults, especially sleep medications and pain medications. So, and supplements, they can end up being on lots of supplements. So you want to check that. So lots and lots of opportunity here. I'm so grateful to be here. And again, I am with the American College of Lifestyle Medicine. There is certification for those through the American College of Lifestyle Medicine. Then for you all, it's through the International Board of Lifestyle Medicine. Very exciting. Over 75 countries who have diplomates of IBLM or ABLM, ACLM. And so please feel free to join us if you'd like. And this is a free offering from ACLM that we wanted to share with you. If you go to our website through the QR code and then type in WHC-22, you can get to that. Here are those resources that I told you about, the references, and I just want to thank you so much for your time and attention today. Enjoy the rest of the conference. Thank you.
Thank you, Dr. Freeman. I really wish that she was with us today here presenting in this conference. Now, this is the end of session number 2. We're going to ask the presenters, speakers, to join us in the discussion panel. Unfortunately, Dr. Rana, she's not with us. She had to catch a flight. We got questions for her. I'm going to ask Dr. Abdulaziz her questions. He might help us with that. First 2 questions, it was for Dr. Abdulaziz. The difference between withdrawal of care and holding medical care at the end of life.
It is a very good question. Withdrawal of medications based on the type of the medication should be considered, because sometimes you cannot abruptly stop some medications while the patient is on. What we are talking about is that nutritional and hydration to the patients, what we can solve that issue. But regarding to the medications, based on the type of the medications, how we can stop. This is because some medications, unfortunately, we cannot abruptly discontinue it. Yeah.
Okay. So the next question is, we know that we have so many kinds of proteins, and they ask what kind of protein is good for chronic disease such as diabetes and hypertension. A certain type of protein, animal protein, plant-based protein, and etc.
Yeah. I'm not the expert matter in types of protein, but I'm working with a multidisciplinary team. So I have a clinical nutritionist with me. So when I have an issue with the patients, directly I will call her and let her to sit with me and how we can set a plan for a patient, because details is related. The details is related. But I told her, please, because when I'm doing the round, the patients will complain to me, oh, doctor, see the meals that they provide me with something I cannot eat. So I call the nutritionist and I will sit with her and we will discuss the plan. And even in the OBD, sometime when I have OBD session with the patients, I consult the clinical nutritionist, because as I mentioned, we are a multidisciplinary team working. But my concern, the main concern, is to provide them with double the needs of healthy adults of protein.
Okay. So the next question is from me. I know that the regular population, that we have certain tracing for the protein intake. What about our geriatric age group? How do you monitor their protein intake? Do you know that this is a sufficient protein intake?
Okay, that's an excellent question. For the geriatric age groups, regarding to how you monitor their protein intake, we should schedule it, as I mentioned, among frequent meals and the variety of foods and how the contents of the protein will be within. That's very important. Even as mentioned by the other 2 experts regarding the geriatric age groups, how you can provide the care, but specifically for protein, it should be distributed among small, frequent meals, and the contents, as I mentioned, usually and almost we consult the clinical nutritionist with us.
It seems like the focus now is on protein.
Yeah.
And we know that meals, we have macronutrients. Macronutrients is carbohydrates, fats, and
Yeah.
protein. Now, we finished from protein. What about carbohydrates? Do you recommend complex carbs, simple carbs? What kind of carbs that we should give in terms of complicity of these carbs?
The complex carb will be difficult to the geriatric age group. So the simple carb, and really the percentage will be in the meals is too much less than the healthy adults.
Okay, but what about simple carbs that could increase their blood glucose, and they would have a hard time acing their diabetes control? So can we do a mix between both? I mean, like high complex carbs with high fibers to promote their GI health and to ace their diabetes control?
Yeah, totally agree.
Okay.
دكتور ركان يديك العافية.
So the next question is for Dr. Freeman. She's with us, or? Dr. Freeman? I believe she's not with us. My question to her, and maybe later on we can ask her through social media or through her email. She mentioned something called social isolation, and it's quite drastic for a geriatric age group. Social isolation is a disabling habit for the geriatric age group, and it's our part that we should be around them to prevent their isolation. How does social isolation affect their life expectancy? Does it affect their psychological status? Does it affect their nutritional status through not eating, or they like to social eat with people? So does social isolation have an impact or on life expectancy?
This is really a very important concept. Let me to tell you about my experience, and maybe Dr. Freeman, she will add more. But in my hospital, we have a hospice unit with 10 beds capacity. Usually when the caregiver is unable to provide the proper care for the patients, I admit him to the hospice unit. In the hospice units, I know that the sons and daughters and all the relatives, maybe they are busy with the life. And the concepts of socialization for this age group is very, very important. So what we will do to support, we do an events for them. So at different time, maybe on a monthly basis, so we let them to celebrate all. We call the family members, and sometime, because for example, one of the sons, maybe we are in the central region while he's in the south. So we will help him through our social services to bring him back with all of his kids and let them to sit with the patients. And so we will do some exercise, and that really has a very, very positive impact on the care of the patients. It will improve even sometime, and we will study that soon. Even the laboratory results, it is improved a little bit with them when they have their family and have socialization with the caregivers.
Okay. Thank you, Dr. Abdulaziz. The last question is for Dr. Freeman. She mentioned, I was thinking when she was saying about the 5 M's, and one of the 5 M's is what matters most. And it got me thinking, what matters most to my mom? What matters most to my dad? What matters most to my grandfather, grandmother? So I was going to ask her, from her experience, what is the commonest answer for this question? Is it people around them? Is it the small little things in life, hobbies, things that they usually do when they were young? So I was wondering about the answer, the common answer for this question. And I'm going to ask her this directly through her social media, because she's not with us today. And I believe this really matters in terms of giving care for our geriatric age group. Thank you, Dr. Abdulaziz. You saved us today for the discussion panel. Thank you.
Thank you, Dr. Rakan. It's a pleasure.
Thank you so much for your wonderful discussions and participation. For now, I want to invite my Dr. Hamd Zayed to honoring our moderator and speakers. Thank you, Dr. Abdulaziz Chani. Thank you, our great moderator. Thank you, Dr. Rakan. And thank you so much for Dr. Rana and Kelly Freeman. Now we have break for 20 minutes, then see you later. Assalamu alaikum. Welcome again all. I'm Dr. Huda Shammari, Executive Scientific Committee member of Hail International Conference on Lifestyle Medicine. Our moderator for the third session is Dr. Rakan El-Atabi. Dr. Rakan, General Surgery Consultant, Medical Director of King Salman Specialist Hospital. Welcome, Dr. Rakan.
Assalamu alaikum. صباح الخير مرة ثانية. So we're going to start session 3. The first speaker that we have, he's Dr. Sami Al-Mhayfir. He got his PhD from King's College in London. He got his master's degree from Indiana University, and he holds his board from the North American board. Please welcome Dr. Sami Al-Mhayfir, and he's going to talk about the influence of lifestyle on dental health.
Good morning, everyone. I'm so happy to be here in Hail International Lifestyle Quality Health. Today's lecture is about the quality of life in dentistry as a practitioner and as a patient. So it's something I hope it's going to be a short and sweet presentation. I'll start with the definition of quality of life. It's all about how good or bad someone's life at certain point. Do you have other mic? Because I like to move. Excuse me. Excuse me. Quality of life regarding patient. This is the first part of the lecture. So we have to understand the quality of life of the patient. How? By listening to your patient. This is the first key. And we have to follow it. And we have measures tool. But as I mentioned, the major tool is listen to your patient to understanding the quality of life of the patient. And we have tool number 1, health days measures, by asking your patient about physical activity, mental health, and any limitations of physical activity, or by listening to your patient. Patient will come to you and report the chief complaint or talking about their lives, as Dr. Freeman said. So I'll start with the first part, quality of life regarding patient oral health as a patient. The first thing, tooth loss. How many one here has a tooth loss? I'll start with myself. I have one missing tooth. That will affect on the diet, nutrition, and overall health. Also, it will affect on biochemical analysis of blood samples, psychological challenges, and comorbidity factors. I'll go through one by one, starting with diet, nutrition, and overall health. If you have patient with no teeth there, will have poor diet. So, and that will lead to what? Reducing vitamins, protein, and studies showed that. Also, the biochemical analysis of blood samples. Studies showed that patient having no teeth there will reduce around 1.1 of vitamin C comparing to full dentate patient. Also the vitamin A and vitamin C, as I mentioned. psychological challenges. And studies show that many ladies eating in privacy or private room, since they don't have teeth there. Also male patient isolate themselves because they cannot eat or they cannot speak in general. So how can we avoid this? By doing prevention for the patient. Start from the beginning. Educate your patient. You have to motivate your patient by doing brushing, looking to see them every 6 months to do follow-up. This is the key answer to our presentation today, or to provide a quality of life. Comorbidity factor with patient has no teeth. It's not necessarily proven as a causal, but it exists there. And studies showed that there's a strong relationship between periodontal disease and cardiovascular disease. So again, how to avoid this? By doing prevention to the patient. Sit with your patient, listen to them, look to their style or lifestyle. Ask them to do brushing every day, 3 times a day. Look to your physician or dentist every 6 months to avoid this problem. If the patient has tooth loss, they have to replace it with implant, crowns. Do not leave your patient without teeth. As I mentioned, periodontal disease, and studies proven that. Obesity, of course, if the patient has no teeth there, how can they eat? They can't. They'll eat like smooth or soft food, carbohydrates, and will lead to what? To be obese. And studies proven that. Completely dangerous patients are 3 times more likely to be obese than those who have 21 to 32 teeth. I'm not going to talk about diabetes also. Other systemic disease, like head and neck cancer, lung cancer, esophageal cancer, bladder cancer, and all proven in studies. I'll talk about the second part, which is something important, the health provider, quality of life regarding dentist or physician. Unfortunately, with time, I might lose my hearing loss. Why? By using the handpiece or the drill. That sharp sound will affect my ear with time. Also the orthopedic physician, anyone using that drill, you have to be careful. We need you here to provide a high quality of health to our patient. So it's simple. How to prevent that? By wearing what? Ear protection. And studies showed that if you use that handpiece for a long time, you might end up having hear loss. So think about yourself first. We need you here. We are the heroes. So to save our population, okay? Musculoskeletal disorder, of course. Sitting with chair for 5-6 hours in the wrong position, you'll end up having what? Neck pain, back pain, muscle spasm, muscle tension. So think about yourself. How to avoid this? Going to the gym. Do massage. And studies proven that if you do that, sitting in a good position, upright position, doing some exercise, will reduce that pain up to 40%. So we have to be careful about ourselves. First, as a provider. Also, mental health, burnout. I was talking with Dr. Ahmed about burnout, stress, previously. early this morning, we have to think about ourselves, mental health. As a physician, you have to sit with yourself, thinking about yourself. You have to have a life, other life than work life. I mean, you need, if you have burnout, stress, do some exercise, do something you like, hiking, drawing, what else? So think about yourself first as a provider, because without thinking about ourselves, we'll end up with having a mental health disorder or problems. As I mentioned, how to reduce it, sleep well. Those who are on call, Dr. Rakan, I don't know. Pay attention to those small details. If you don't sleep well, you won't focus on your treatment. And this is our goal here, as a physician, to provide a good treatment to our population. Thank you. If you have any questions, I would like to acknowledge University of Hail, Dr. Agad al-Dakhil, to organize this lecture with me. And if you have any question, please contact me through that.
Thank you, Dr. Sami. And whatever he said about on-calls is correct. I live by that daily. For the next topic in hand, as we all know that certain habits, they are influenced by the economical impact on ourselves. The cost of a habit will influence the continuation of this habit or not. So please welcome Dr. Mohammed Tanir. He's the chairperson of Research Monitoring Department and Head of Research Business Strategy Department at King Fahd Medical City, Riyadh. Dr. Mohammed Tanir.
Assalamu alaikum. Thank you for inviting me this year again. I was here last year and I much enjoyed the experience. So I'm happy to share with you one of my published study by WHO in health in Eastern Mediterranean Health Journal published by WHO. So this talks about tobacco price increase and consumption behavior among male smokers in Saudi Arabia, a community-based study. So as a background, we all know as toxic substance are one of the pillars in lifestyle medicine that we try to eliminate or reduce to the maximum because of their bad effect on overall health. So tobacco consumption is one of the main contributors to public health problems, to cardiovascular disease, to cancer and others. And it's killing approximately 7 million people worldwide each year. So on average, 6 million deaths is attributable to the direct use of tobacco, while an average of about 1 million result from secondhand smoking. And this is really important. And this also encourage lifestyle medicine providers to work on this point. So according to global health observational data, more than 1 billion people smoked tobacco in 2015, and nearly 80% of them lived in low to middle class income countries. So countries for the last 3-4 decades thought about increasing price of tobacco in order to reduce consumption of tobacco. But is this effective? Was it effective? Was it standardized among all countries? Let's see. So after Joining the WHO Framework Convention for Tobacco Control in 2005, Saudi Arabia Ministry of Health initiated a national tobacco control program with remarkable efforts. And they decided in 2017, June 10, 2017, to double the tax on tobacco. Why? Because aiming to reduce consumption or the number of smokers in the kingdom. And as I just said, increasing the price, it was considered to be highly effective policy to reduce tobacco use and eventually decrease the associated morbidity and mortality with smoking. So reducing tobacco is a key component of the Healthy People 2030 vision in Saudi Arabia and part of the National Action Plan for improving health of all Saudi Arabians. This study was conducted in 2018, and the main objective behind it is to assess the association between the increased price of tobacco in Saudi Arabia and the consumption behavior among male smokers in Riyadh. While I know the use of only male is a limitation of study, but if we go back 6 years ago, like assessing smoking behavior from female Saudis was really a burden. So it wasn't really feasible and practical. And as you know, for any research, we have to look for its feasibility. So it wasn't really very acceptable to ask a female if you smoke and how many cigarettes do you smoke or so on. So that's why it was restricted to male adults in Riyadh city. So what kind of study we conducted? We conducted a community-based cross-sectional study between April and October 2018 in all 5 districts of Riyadh among male smokers aged 15 and above. I know that the official definition of adult starts at 18, but usually in healthcare system in Saudi Arabia, 15 is considered adult somehow by admitting children of 15 years to adult wards, and also because we know the percentage of adolescents that smoke, so we decided to reduce the age to 15 in order to see what is the prevalence of smoking about this subgroup also. So where participants were approached in public place and mainly in coffee shops. It's really convenient, and usually, you know, smoking a cigarette is usually associated with having a cup of coffee. So a self-administered questionnaire was created on a depth review of the literature. And the pilot study was conducted on 50 Saudi males. And based on the expert recommendation and the outcome of the pilot study, few questions were reformulated and amended to enhance the questionnaires' validity. Reliability was measured using Concrach-Bach coefficient and was really acceptable of 0.72. So the pilot survey data were not included in the final analysis because, as I said, few questions were reformulated. The questionnaire has 2 parts: sociodemographic factors, characteristics, and questions related to tobacco consumption. The questions regarding sociodemographic characteristics included age, educational level, marital status, employment status, and yearly incomes based on Saudi Arabia GDP per capita purchasing power parity, which was equal at that time to $45,821 per year. The question regarding tobacco consumptions were your opinion about increasing the price of tobacco, the type of tobacco you consume, change in consumption behavior based on the new taxing, change of cigarette brand to one with a cheaper price, number of cigarettes smoked before and after taxation, number of years as a smoker, place where your cigarettes or tobacco were purchased, price of preferred type of tobacco, and what is your current tobacco use. The sample size, according to 2016 census of the population of Riyadh, there were 3,747,557 males aged 15 and plus in Riyadh. So given the prevalence of smoking based on previous literature to about 25% in this age category, so the population will be cut down to 936,889 smokers among male aged 15 and more. So to generate a 95% confidence interval from this representative sample with 2.5% margin of error, a sample size of 1,534 male smokers was a must. So the study is really focused on the price elasticity. We all know when we talk about price elasticity in health economy, that means we want to see if the demand of a good is still the same, decrease or increase after increasing the price. So this is why reporting this study was mainly focusing on the value of price elasticity. So price elasticity of demand equal percentage change in quantity divided by percentage change in price. And I put here the formulas, how we calculate the price elasticity. And as you see, our price elasticity of demand was 0.2. What that means? That means our demand for tobacco is price inelastic. That means people won't get affected and change their opinion even if you increase much the price. They need this good and they will get it. So any price elasticity that is below 1, that means the demand is not really affected by increasing the price. And usually this has happened not only for smoking, but for all necessary goods that we need on daily basis. Like even if the price of education is getting higher, we still getting it. Price of health services, we still getting it. Price of certain foods, we're still getting it. So this is what this study showed, that the price elasticity of demand is 0.2, and it is considered as inelastic. That means it's not really affected by the increase of price. Here is a table that shows the association between participant demographic characteristics and changing in consumption's behavior. As you see, we had only 2 socio-demographic factors that were significantly associated with the decreased smoking, which they are the employment status and the GDP per capita PPP, which means the 2 factors are related to financial status. So if you are employed, your percentage of being affected to quit smoking or reduce smoking is significantly less than non-employed. And there are also people who make more money per year are significantly less affected to reduce smoking than those make less money. Other factors, marital status, educational level, and age category were not significantly associated with consumption of tobacco. Here we see these questions, the percentage, a very important thing here that the majority of people did not agree, and this is, normal and natural to get. People will not accept to increase prices. So 60.5% were not with the decision of increasing prices. 85.7% their preferred type of tobacco is cigarettes. Change in consumption behavior. As you see, this is really important. Only 1% of participants in this study quit smoking after price increase. 15 people out of 15,000 some. So it's 0.9 something percent. But what it was really important that people reduced the number of cigarette smoking. And we all know that smoking has a temporal and quantity relation with as a risk factor. Like people who smoke 30, 40 cigarettes a day are a higher risk for cardiovascular, for cancer than for those who smoke 10 or 15 cigarettes a day. So smoking is a dose-related risk factor. So this is really important that they could, even though we were disappointed that they did not stop, but 25.6% of the population reduced smoking. This is good. But what wasn't good, and it's challenging for future planning, is that 15.1% change to cheaper brand. So this is really, really bad because we know that cheaper brand have a worse quality. Okay, and also people try to find, like all other things, try to find another place where they can get their cigarette for cheaper, so they get it from duty-free or from other countries to escape this increase in price. So as I said, these we talked about, employed were less likely to stop. People with better GDP per capita, PPP, also were significantly less likely to reduce smoking. So usually a decrease in cigarette consumption could result either from reducing the number of smokers. We couldn't achieve in this study, only 1% did it, but reducing the number of cigarettes consumed per smoker, 25% of the population did. The results of this study showed that increasing the price of the tobacco products was associated with a significant reduction in the number of cigarettes consumed by participants. We talked about this. I want to see the future increase in cigarette price might increase the price elasticity, which could suggest a more effective use of tax increase to control tobacco. Also, two primary concerns that we talk about, cheaper alternatives, lower quality tobacco products were expressed by 15%. And we want to say that people escaped from buying high-priced cigarettes by going to duty-free shops or other sources. 25% of people can get their cigarettes from other places. The limitation of study, this is a self-questionnaire, so we don't have a biomarker validation. This study was done only on males, and the reliability of data is dependent on the respondent recall and honesty. The conclusion, that it's really important for policymakers to develop a strategic plan to adopt new measures to control smoking by educational programs, by enhancing the knowledge of the community regarding the negative impact of smoking on health, and by really like applying lifestyle medicine. So once we show people and we guide them to quit or be away from smoking at the lifestyle medicine, this will also bring positive input in this domain. Future research, larger scale, including women, is needed in this area. Thank you so much, and wish you a very pleasant remaining of this conference.
Thank you, Dr. Mohammed, for this great presentation. Need to remind you that we have QR codes for questions and evaluation. If we can put the QR codes now for them to capture it. So for the third session, third speaker, he's a nephrology consultant, associate executive director of academic affairs in King Fahd Medical City. He's also an associate professor in Al Faisal University. Please welcome Dr. Khalid Al-Matham.
So I'm going to talk about the sodium-potassium renal homeostasis, and here are my disclosures. And this is the outlines. I'll talk about the renal function, sodium and potassium homeostasis. So starting with a simple definition, just going back to the physiology. So homeostasis is maintaining the total body content at a stable and normal level, even in the face of changes in dietary intake or endogenous production rate. And if we look at the functions of the kidney, we know that it handles the electrolytes like sodium, potassium, chlorides, and others. It maintains the osmolality of water and the body, acid-base balance through bicarbonate, which is the extracellular volume buffer, minerals like calcium, phosphate, and magnesium, and waste material like urea, protein, creatinine from muscles, uric acid, and to get rid of them out of the body. In addition to that, we have also the endocrine function of the kidney cell, like a production of erythropoietin, which is important for hemoglobin production, 1-alpha hydroxylase enzyme, which is in the kidney, which help to convert the inactive vitamin D to active vitamin D, 125 oxyhydroxide vitamin D, production of renin, which is important for the control of blood pressure, and paracrine and autocrine functions like production of bradykinin, prostaglandins, endothelial factors like nitric oxide and insulin. Just the functions that I mentioned now, I'm not just limited, we have more, but I focus on the main ones. And also it's important for the blood pressure control. As you know, the kidney is a critical organ in the maintenance of the normal blood pressure. Because of the homeostasis of sodium and water, it maintains the extracellular fluid volume, which is one of the components of blood pressure. And also through the control of the renin-angiotensin-aldosterone axis, and through the production of vasodilatory substances. All of these components, the three components, help to maintain the blood pressure control within the normal range. Other functions of kidneys, like the catabolism of small peptide hormones like insulin. And as you know, once the patient reach like end stage or like late stages of renal failure, what happened? They have reduced need for insulin, and some of them, they go into hypoglycemia. So in some cases, we stop the diabetes treatment for them, or we use a small dose of insulin or short-acting oral hypoglycemic agents because the catabolism of insulin is reduced. Also, the kidney can produce glucose via gluconeogenesis during fasting. And it's also responsible for elimination of many medications. That's why if we have a change in eGFR, we have to adjust the dose according to the level. If we talk about the normal fluids and electrolytes, so almost the fluids constitute 60% of healthy adult weight. It's mainly water, 60%, and water necessary for normal cellular function. And it's a medium for metabolic reactions and transports of nutrients and waste product. Also act as a lubricant for joints and insulator and shock absorbers, and also help to regulate and maintain body temperature in the extreme of changes. If you look here in this table, we can see that almost the ICF or intracellular fluids, almost 2/3 of the total body water, and the extracellular fluids is almost 1/3, and it's divided in the interstitium, intravascular, and transcellular. And as you can see here, that whatever intake to the body. It's almost distributed as 2/3, 28 liters in the cells, within the cells, and almost 14 liters are distributed across the three component. And the output of the fluids that we take can be through the kidneys or through respiration, feces, sweats, and skin. If we talk about the water and sodium balance, of course, if we say balance, that means the gain equal losses, and there will be relatively small changes in sodium, and this is accommodated by the changes in the ECF volume. So we have to maintain the certain level of sodium within the body. And the hemostatic response involves two parts: the antidiuretic hormone control of water loss and retention, so by the kidney and thirst. So if we are thirsty, we have release of ADH, which will retain the water inside the body, and the fluid exchange between the ECF and ICF to maintain a good amount of water, so there will be no changes within the sodium. Here is just the table summary. I will not go through it, but if you see, if we focus on the sodium and potassium, we can see the primary route of exchange for the sodium is the urine, sweats, and feces, while potassium, it's mainly urine, although that the intestine can help to excrete the extra potassium. And the recommended daily dose of the intake for sodium is 1,500 milligram, and the potassium is almost 4,700. I'll talk about it in the coming slides. So I know this is like a complex slide, but if we take what will happen if there is a rising in the sodium level in the body, so the homeostasis here is disturbed. So what will happen that the sodium in the ECF will be increased. So the osmoreceptors in the hypothalamus will be stimulated. We have ADH hormone release, and we will have recall of fluids because ECF osmolality increased and water need to shift from ICF to ECF to reduce the sodium level in the ECF. And then once we have the more fluid coming into the ECF, the sodium level drop, and then we have restored hemostasis and decrease, and we go back to the homeostasis status. What happens if we have a fall of the plasma sodium levels? Actually, if we start here with the homeostasis is disturbed because the sodium in ECF is low, osmoreceptors are inhibited, so the ADH is not released, or the secretion is decreased, and we have water loss reduce, and ECF volume concentrates ions, and this restores the sodium level in the ECF, and we go back to our homeostasis level. Of course, this cycle is done without we are thinking about it, and this is happening on daily basis in our bodies. But if there's anything that disturbs the cycle for increasing the sodium or lowering it, like for example, if you have a problem in the brain or we take some medication, this cycle will not take place, and we will have a chronic hypo or hypernatremia that we have to manage. Again, as you said, the sodium balance, it's important for the control of blood pressure. So if we have increased blood volume and pressure, what will happen? We have the natriuretic peptide release, and this increased sodium and water loss in the urine. It will also inhibit the thirst feeling, and this will lead to inhibition of ADH, aldosterone, epinephrine, and norepinephrine release. And if we have decreased blood volume and pressure, what will happen? The endocrine response increase ADH release, and we'll have retention of fluid inside our body. Aldosterone, this will lead to sodium retention in the body, and RAS mechanism will be stimulated. And the opposite body responses to above, as we see. So there is an ongoing process to maintain the blood pressure throughout the day. What happened as dysnatremia complication, as you know, once the dysnatremia, for example, if the sodium is lower or higher than usual, if it exceeds 48 hours, it converts from being acute to chronic, and the management will be different, and we have to be careful about that. So in case of acute hyponatremia, we have more fluid into the ECF, and we have that need to shift to the ICF. In case of hypernatremia, we have more salt, like sodium chloride, and we have to have the water move from the ICF to the ECF to reduce the amount of sodium that we have. If the chronic hypo or hypernatremia is there and we do rapid correction, we try to restore the sodium level, what will happen? We will have the ODS, or osmotic demyelination syndrome, which it has a long-term consequences on the nervous system, which in most cases are not reversible, and it's serious. So we have to avoid, and we have to make sure when we do the correction that we know over how long these changes happened, or we have to take it slowly unless there is like a drop of the GCS or there is seizures. This is one study actually, and they looked at the excess of level of sodium that you take and how much sodium affects your health. And this is from the United States, and we can see that there's 9 out of 10 American consume too much sodium, and almost 70% of the sodium comes from processed and restaurant foods, and 11% is added while cooking and eating, and more than 14% occurs naturally from the food. And if we look here, the recommended sodium is almost 1,500, but here the actual average intake of the American people is 3,400. So that means we are not doing good of the salt intake that we have. And what's the impact to our health? So the excess will lead to enlargement of the muscle, of the heart muscle, headache, kidney disease, osteoporosis, stroke, heart failure, and others. And also, the excess of sodium will lead to retention of water and will lead to puffiness, bloating, weight gain. And just if we want to summarize, we have to remember that if we have a sodium issue, it's a problem of water, and if we have edema, it's a problem of sodium. Here is just one study showing the relation between the amount of sodium consumed and the mortality. And as you can see here, the higher the sodium intake, the higher the mortality, as shown by the hazard ratio. So we have to be careful about the amount of sodium that we take because it has its own consequences, regardless if we have hypertension or renal disease or not. Now I'll move to the potassium balance, and we'll talk about the potassium. As you know, again, the gain equal losses, and major gain is through the digestive tract absorption. We absorb almost 100 milliequivalent per day, and usually the major losses is by excretion by the kidney, and the primary ECF potassium regulation by the kidney since intake fairly constant. And usually the hormone that is important for the control is the aldosterone, regulating the sodium potassium exchange pump in the distal collecting tubule and the collecting duct of nephron. And also the low pH in the ECF can cause hydrogen ion to be substituted for the potassium. So what will happen, the kidney trying to retain the hydrogen and excrete the potassium in the urine. If we look at the distribution, potassium is the highest in the intracellular volume due to the exchange pump. So it's almost 135 milliequivalent versus 5 only milliequivalent in the ECF. So what will happen once we ingest the potassium? The intake, it will go to the body, and it will be stored in the liver. And once we have absorption, you can see here the level of potassium in the serum will go up, and this will send a stimulus to the kidney to excrete more in the urine, so we don't need the extra potassium in our body. And this also, once we excrete a lot, it will send feedback that it's like a continuous loop for feedback between the GI tract and the liver. So we can say almost 95% we will not have abnormal potassium level in the body if we have normal kidney function. Okay, if we here just see in this slide, so once we have digested potassium in the body, what will happen? We have here the liver. The potassium will be stored in the liver and also in the skeletal muscles. And if we have excess going into the ECF, the brain will send the stimulus also to the kidney to excrete the extra, as we mentioned, through this mechanism. So when does hyperkalemia occur? And this is one of the most serious side effects that we have. Hyperkalemia occur only if the balance is disturbed. And you can see here, all, as I said, if we have normal kidney function, the abnormality will not happen. So if we have renal disease, if we have decreased chronic excretion, if we have decreased uptake due to, for example, acidosis or other reason, or if we have medication that might cause rise into the potassium, increased dietary potassium intake, factor that might cause cellular release. Let's now talk about these mechanisms one by one. So I'll just choose the most important ones. So if we have decreased potassium excretion, and this mainly happen due to damage in the renal tubules, the ENaC channels and others. So we will not have a proper excretion. Sorry, I apologize. There was a disconnection. And the second one, reduced potassium diffusion in the tubular fluid impairment, and then aldosterone axis. So if we have aldosterone deficiency, reduces sodium reabsorption through the ENaC sodium channel, what will happen? Hyperkalemia will happen. And this is usually, we see it common scenario in diabetic patients because they have aldosterone deficiency or dysfunction, or as in patient in Addison disease. And in diabetes, we have type 4 RTA. Also, reduced potassium elimination, as in metabolic acidosis, is one of the causes. Just a complete, like it's a complex mechanism that I will not go on through details. And I think one of the most important one is the several drugs that can alter the potassium homeostasis, like non-steroidal anti-inflammatory drugs, direct renin inhibitors, ACE inhibitors, ARBs, low molecular weight heparin, aldosterone antagonists, potassium-sparing diuretics, for example, like also the antibiotic like trimethoprim, beta blockers, some of them, and this is mainly postprandial, and calcium urine inhibitor. All of them, they have different mechanism into the kidney that they can cause hyperkalemia. So what is the significance of having hyperkalemia? As you know, it can cause muscle weakness, it can lead to arrhythmia, and it's important to note that it's not necessary if we have hyperkalemia that we will go through the ECG changes that we are familiar with. In some cases, patients can go from normal sinus rhythm to cardiac arrest immediately.
Dr. Khalid, I'm sorry, but we have only 2 minutes left for the allocation
time.
Sure,
I will finish. So if we have disturbance of the balance, if the potassium is less than 3, it can be caused by diuretic or aldosteronism. The symptoms is mainly weakness, followed by paralysis. If we have hyperkalemia, that means the potassium is above 6 and can be caused by chronic low pH, kidney failure, or drug promoting diuresis by blocking sodium potassium pumps. And symptoms can be muscle spasm, including heart arrhythmia. Just this is a study showed that patients who have multiple risk factors, if they have hyper or hypokalemia, the mortality is increased. So it's a serious thing. So this is just one study I want to share with you. We'll talk about the lifestyle intervention to improving health outcome and enabling people to live well with kidney disease. And it's like a package that doing or having an improved lifestyle will have an impact on maintaining the healthy or the health of the kidney. It will enhance life participation of the patient and their families, and also will address unpleasant symptoms. So it's important that we adapt this concept of lifestyle medicine to improve the kidney outcomes. Also, we have an example from lifestyle medicine, blood pressure. As you know, whatever we do as improvement in the lifestyle will have impact on the blood pressure reduction, and you are familiar with the DASH eating habit. With that, I would like to conclude, and thank you so much.
Thank you, Dr. Khalid. When we say lifestyle modifications, when we say lifestyle change, the first thing that comes in mind is obesity, increasing weight and trying to drop weight, which is linked to all kind of other comorbidities. It starts with obesity and it stays in obesity. For the next speaker, we have Dr. Walid Al-Bakr. He's going to talk about obesity, updated medical management. He is an associate professor and a consultant endocrinologist. Please welcome Dr. Walid Al-Bakr.
اوكي السلام عليكم ورحمه الله وبركاته. بسم الله الرحمن الرحيم. الحمد لله رب العالمين والصلاه والسلام على رسول الله عليه اشرف الصلاه والتسليم. I would like first to thank the organizing committee for inviting me for this excellent meeting. I know I'm in my last lecture. I hope you stay awake, but I will try to make it interesting and concise as much as you can. So this is my first time to come to Hail and really enjoy the gathering and very impressive attendance and organization. And thank you all. So I'm going to talk about, I'm coming from Khobar city, and based on Imam Abdurrahman bin Faisal University, and working over there, we do a lot of researches in obesity, and this is my interest, to make people healthy, fit, and happy. All of these is just not a cosmetic problem, but also it is a medical problem that is alarming in Saudi Arabia. We know that the obesity is associated actually with multiple comorbidities. It's actually it is a chronic progressive disease relapsing because of excess fat, and that results in multiple medical issues. It has a mechanical problem. It can cause osteoarthritis, disc prolapse, and also have a metabolic problem. It can cause, type 2 diabetes, hypertension, dyslipidemia, fatty liver, and in the same time also can have an impact on your psychological, like causing depression and anxiety and social isolation. So obesity is linked to more than 225 diseases. So it is actually the core of many medical problems. And if you look for the treatment for obesity, and always we stay, like you see in social media, lifestyle is very important. But remember, the obesity is not only lifestyle. It's a complex disease. There's involvement of the genetics. There's involvement actually of environmental factors, and it is integrated together. Sometimes you do exercise, you go to gym, you do all of the things, but you cannot achieve your target weight, and that's really what makes us frustrated, and probably we quit going to gym, or we quit actually continuing that one. But ideally is actually when we combine the lifestyle in addition to our medical therapy. And I'm going to go over my talk about the medical therapy available approved by Saudi FDA for using for obesity and overweight. Now, all of these medications is approved for BMI more than 30 or BMI more than 27 with comorbidities. So that's actually approved this medication. We start with our first baby, which is the liraglutide or the Saxenda. This medication is basically a human GLP, is actually released from the GI tract, and it's actually involved in or discovered in 2014, and a study is called a scale trial. The first thing that happened is دواء اسمه Victoza, and this is used actually for the diabetes, and they found this medication, it can control your appetite and can reduce the weight. So then they found that at the higher dose of the liraglutide, they found it reduced more weight. So they developed this medication, which is called Saxenda or the liraglutide, and they study this medication in a different clinical trials called a scale trial, including in patients who are obese and pre-diabetic, those who are diabetic, and also they studied at the level of sleep apnea, so different things. And what they found actually, this medication, they follow those patients, they saw how many percentage of those patients reduce more than 5% of their body weight, how many of those who reduce more than 10% of total body weight, and what they found actually, if you look for example, 52 weeks, a sample of 3,000 patients, they found that more than 63%, they achieve actually more than 5%, and more than 33%, they achieve actually more than 10%. So if your weight is 100 kilos, so you might reduce about 10 kilos, the chance about 30 to 40%, you might reduce that one. So that 10 kilos, in addition to lifestyle, we see cases that go to 20 kilos if you combine with exercise and with diet. And that really make a lot of difference in your joint pain, and your osteoarthritis, back pain, your fatty liver, your pre-diabetes, your sleep apnea. All of these, actually, we noticed that the patient noticed a good benefit. And also, even the sleep apnea, we have a lot actually of collaboration with people from Palmo. They refer patient to us for sleep apnea, that to reduce weight, that might help them actually sleep apnea. Our orthopedic colleague also, they send us patient having no knee osteoarthritis and disc prolapse, and we help them to reduce weight and probably help them to have more recovery post-op. So, this is the categorical weight loss, and you can see that more than 15% of body weight, you can reduce it about 1/4. They can reduce more than 15%, and I think this is also impressive. If you reduce from 100 kilo to 15 kilos, drop 85. So I think this is also a very effective on overall health. I'm always convincing patients that this is not a cosmetic issue. It is a medical issue, and it is a disease that should be treated. And all the societies now recognize obesity as a disease which is treated just like diabetes and hypertension. And we treat to target to the ideal BMI, and that's what we need to do. Now, other medication which is available in the market, and probably are knowing that one, is called the semaglutide or the Ozempic. And the semaglutide, the higher dose of semaglutide called Wegovy, which is not yet, the higher dose of semaglutide is not yet in the market, but available in US and UAE. But what we have in the Ozempic semaglutide is a medication that's used for type 2 diabetes. And again, these given once weekly injection have longer half-life, just the same family of the GLP, and its work basically of suppressions your appetite, and of course increase the satiety, and you feel full all the time, and basically it's have an escalation. All of this medication have a GI side effect. It can cause nausea, vomiting sometime because it delayed gastric emptying. So we start slowly and we go gradually. So up to the highest, what we have is up to 1 milligram. There is 0.25, 0.5, and 1 milligram, and up to 1 milligram. This is what's available in Saudi, and outside they can go up to 2.4. And let's see what the study actually done in these medication. The trial called a Step 1 trial is published once weekly semaglutide in patients who are overweight or obese. And actually they include sample of 1,961 participants. They include male and female more than 18, BMI actually, as I mentioned, more than 30 or more than 27 with comorbidities, and A1C less than 6.5. And then they follow those, after escalation, they randomize it to either placebo versus the semaglutide. In addition to the lifestyle intervention, we instruct the patient to do exercise and more compliant with diet, and together synergistically with these medication. they look at actually the primary endpoint, the percentage of the weight loss, and they look to the responder. And the secondary endpoint, they look at other parameters. For example, the blood pressures, your HDL, your LDL, your triglycerides, A1C, blood sugar fasting, insulin resistance. So they want to see the other cardiometabolic factors. And I'm going to show you that in a minute now. So this is impressive, actually, when you see that in the higher dose of semaglutide, actually, the reductions go up to 16% of the total body weight. And that's really very impressive compared to the placebo. And you can see, compared to the placebo, very significant. You might go, if you are 100 kilo, you might reduce at the high dose up to 15 or 16 kilos. And again, this is important. This medication is good for those who struggle in their diet and they did not reach to the bariatric surgeries, and they are sitting in the middle and they need some help with the endocrine people. So this is the categorical weight loss, and you can see more than 92% lost more than 5%, more than 74% lost more than 10%, more than 15% lost 15%, 50% lost more than 15%, and you can see more than 34% lost more than 20%. I think it is very impressive. Losing 20 kilos with the lifestyle, I think this is something, for no doubt, it transforms for better health. And remember, when you reduce weight, you can do more exercise, you're more motivated, you go and you're more socialized. It improves your mental health, your psychological health, and your physical functioning in the community, and engage more in the community. Now, then, of course, in the change of body compositions, you can see there's a reduce in the total body fat. In fact, when they look at body fat composition, they found the body fat is actually reduced, and the lean body mass does not much actually decrease, and that is good about this. This is DIXA scan, and of course, change the metabolic parameter. You can see the fasting blood sugar is also reduced because this medication used also in diabetes. Also, your insulin level and insulin resistance and HOMA is improved. So insulin resistance also improved. So that's, again, there's something very important. And you can see those who are pre-diabetic, which is a lot in the community in Saudi Arabia and also in GCC country. You can see a lot of people who were in a pre-diabetic, actually they become normoglycemic, and this is because of reduce of the visceral fat, which is involved in insulin resistance compared to the placebo. And if you go look for the cardiovascular risk factors, which is the total cholesterol reduce, LDL reduce, HDL increase, triglycerides significantly reduce, you can see, and the free fatty acids also is decreased. So all the cardiovascular, lipid profile getting better. And if you look for the waist circumference, is also very impressive. Actually, you can see that you can change about 13.5 centimeters in your waist circumference. And this one, which linked to, of course, in the cardiac problem. And the systolic blood pressure improved, the diastolic blood pressure improved, even the CRP also is improving and getting better. So if you go for the adverse event, this medication not without side effect, of course, it should be given, not self-medicated. You should, with your physicians who find the proper patient, usually we exclude patients who have family history of medullary thyroid cancers, those who have a previous history of pancreatitis. So we try to avoid this. Those who have untreated, GERD or, severe reflux or GI symptoms. So you need actually to choose the right people. We see a lot of population who had bariatric surgery and they regain weight after bariatric surgery. We can also use these for those patients. So the side effect, usually remember, it is a transient, and just you need to take low-fat diet and you escalate the dose gradually. So that's the way to minimize as much as you can the side effect of this medication. So you can see nausea, vomiting, and some of the people, they think it's caused gallstones, but in fact, the reduction of the weight is the one which caused gallstones, is not the medication itself. So that you need to be careful in that. Local allergic reactions can happen. Some people who are emotional eater, they report some mood swings. So we saw some cases who have some mood swings, especially emotional eater. So if we look for My third medication, which is approved by Saudi FDA, is the tirzepatide or Mounjaro, if you know that medication. And this is actually launched for the past year, last May, exactly now 1 year from launching Mounjaro in our country. We are one of the leader starting this medication after US and UAE. And this medication approved as type 2 diabetes medication. And then 3 months ago, Saudi FDA approved this medication to be used for BMI more than 30 or BMI more than 27 with comorbidities, and it's available in the market. It's basically a once-weekly injection called tirzepatide. It's a unique molecule which have a different mechanism combined, both GLP and GIP, both secreted from the GI tract, the K cells and the L cells, and it affects the brain to suppress your appetite. And the good thing, because it's a block 2 molecule, it helps actually to less GI side effect compared to other medication. So let me just skip that one, and just to show you this total molecule, the GLP and the GIP1. Basically, it decreases the glucose-dependent insulin secretion. That's why it's good for type 2 diabetes. It increases the beta cells, so it preserves beta cells function. It actually, because there's misunderstanding, it causes diabetes. This is not right, because a lot of patients saying wrong concept from the social media. And the good thing about this molecule, it also improves the glucagon secretion, so less hypoglycemia compared to other molecule. And then also the GIP have minimal effect on gastric emptying, and the GLP have gastric emptying. That's why the nausea and vomiting is less compared to semaglutide and the liraglutide or Saxenda. So the study is called Ceramont trial. The study in diabetes is called CERBAS, but the study for obesity is actually called Ceramont trial. It's the efficacy and safety of tirzepatide once weekly in participants without diabetes who have obesity or overweight with weight-related comorbidities, as a randomized controlled trial published in New England Journal of Medicine just about 2022. And this is called Ceramont trial, the famous one. And what they did actually, basically, they used the inclusion criteria which we mentioned, and they randomized the cases to 5 milligram, 10 milligram, and 15 milligram. This is the dosage. There's different dosage, start from 2.5 up to 15. They use 5, 10, and 15 versus placebo, and they continue to 72 weeks, and they look at all the weight parameter. What we have the result. The patient characteristic that we have is these things. Most of the participants were female, 67%, 2/3 were female. Mean age is 44 in the study. Different races involved. The mean weight is actually 104 kilo, and the BMI is 38. If you go to surgeon, bariatric surgeon, he might do bariatric surgery for you at this BMI. So the BMI used in this actually is 38, and the mean circumference of the waist is 114. Those 40% are pre-diabetic, already pre-diabetic, and systolic blood pressure mentioned GFR was normal. So so what we have, this is the result, and you can see the treatment regimen estimated. You can see that a dose of 5, 15, and dose of 5, 10, and 15. You can see at higher dose you can reduce 23% of your total body weight. So that's really almost near. I'm not saying same, but near to balloon and near sometimes to sleeve. We reach near to that one. And I think this is very impressive result. A medication that can help the issue without interventions surgically. I think that is something very impressive. And you can see at only dose of 5 milligram, you can reduce 15%. Dose of 10 is 19%. Dose of 10 is about 21%. So if we look for categorical weight loss, you can see most of the patient is from 60 to 70%, they can achieve their target. They can achieve the target that they want. And that's from 60 to 70% in all dosage of 5, 10, and 15. So if we look for change in body compositions, yes, when they did in-body analysis, they found that it's actually reduced the total fat mass They reduce the visceral fat. That's why very impressive. Can reduce your circumference from 15 to 19 centimeters. And then the total, unfortunately, the body muscles is also reduced. So that's something we have to, exactly what happened in bariatric surgery. This also can happen. And you need to instruct the patient to do resistance exercise and also try to maintain your protein intake so you don't go in muscles waste. I'm almost near to this is my last lectures. I think I'm the last one. So just give me 2 minutes exactly, inshallah. طبعا waist circumference, and you can see how the difference, 18 centimeters. Anybody check his visceral circumference, or I mean, every day? Okay, I think that's also good parameters. We don't do it in the clinic, but I think you check your circumference is very important. And I think it's very impressive. You can see people who have normal BMI, but they have big visceral obesity. And that one is which costs you actually medical issues more than the generalized obesity. And all of that, you know, and this is the lifestyle related actually. And the A1C is improved, and also the systolic blood pressure improved, and also the diastolic blood pressure improved, and all of this because of the obesity, okay? And if you go for the fasting, those who have insulin resistance, you can see also is actually improving, and the HOMA is increased. If you look for the lipid profile, so you look for, again, LDL, HDL, and triglycerides actually also improve. What are the side effects? Well, side effect is mainly GI, nausea, vomiting, diarrhea, constipation, headache. All of these is expected. It's very low, very low. If you take a small fatty meal, small meals, avoid the full falafel and, you know, the fatty food as much as you can. Sometimes I give them metoclopramide or Dombi or Motilium to help them. Sometimes I give them Nexium, so to pre-medicate them to prevent the GI side effect, but usually it's a transient and it is a dose dependent. So if you increase the dose, the more side effect. And the highest side effect, you see it at the dose of the 15. So sometimes the patient stop the medication. So you need to follow or keep in touch with your patient all the time. So this is the side effect, as I mentioned. Okay, so again, same side effect which I mentioned here. And so in summary, these medications, it changed from baseline to week 72 in body weight, and proportion participant to achieve more than 5% weight reduction were superior to placebo, and all cardiometabolic measures were improved on tirzepatide, and the overall safety were similar to other GLP, which we know from the market for all the past 10 years. And the most common reported side effect is GI, which is mild and transient. And this is how it looked like. It is starting from 2.5, 5, 7.5, 10, 12.5, and then 15. Use the same escalation for Mounjaro, for the type 2 diabetes, and also for the obesity. So if you put all the medication together, you can see the Ozempic at the small dose, it reduced about 12 kilos, and you can see Mounjaro on the top. You can go up to a percentage of total, 24% of the total body weight. And then, so this is my last slide. I don't know if there's a bariatric surgeon here, but always I present this talk in front of bariatric surgeon monthly club. All of them were surgeon, and I was the only endocrinologist. I was ready to be attacked by them, and this one irritated them. I told them it looked like the medical sleeve are on board. Thank you very much.
Thank you, Dr. Walid. The war of bariatric surgeons and endocrinologists will never end. Everyone would say that I got the major effect on the patient, while both of them working great with patients. So I would like to thank Dr. Walid Al-Bakr for his presentation, and I would like to invite all speakers to join us in the discussion panel, please. So as expected from this session, it's a hefty session with a lot of important information. We have a lot of questions. And I'm going to start with the first question is, as expected, directed to Dr. Walid, because nowadays, the amount of marketing for these non-surgical methods to reduce weight is extremely high. Even non-physicians, even people who are experiencing these medications, they would start to market it to their relatives and people around them. So the first question is, in terms of for liraglutide, what's the effect of fat-soluble vitamins? Whether it will result in vitamin deficiency or not, or any deficiencies related to the vitamins, not necessarily fat-soluble.
Okay. Well, the first part I want to comment that the problem actually with this medication, the obesity bias, they give it for everybody. So it's not for everybody. You need to give it for the right people that they might benefit from this medication. So that's number one. And always I tell my patient in the clinic that why I'm treating you is basically for the medical issues, not for cosmetic reason. And I will emphasize on this with my patient and the benefit of that one. So we need to revise this. Now, in terms of the nutrition deficiency, well, in terms of liraglutide or Saxenda or semaglutide, I mean, the weight is 10% reduction, so it will not much affect. But maybe with the tirzepatide, the studies in long term is still lacking. So a nutrition deficiency can happen at long term if we take it for years and with a very low, intake. So that can affect your nutritional. Not specific vitamins, but iron deficiency, it can happen. B12, folate can happen. So sometimes, especially ladies, I do CBC and iron because it's very common to them. I do B12 folate for them. So and I replete it together with the medication. But something to this area is deficient, and more studies will be we need it actually at the long term.
Okay, thank you. So you said that you just came to Hail. This is your first visit to Hail.
Yes.
And the next question, we will see if you did your research about Hail or not. What's the ranking of obesity in Hail compared to other cities? If you have any information about this.
Well, if you look actually, obesity globally is changing. And Saudi Arabia, people going from here and there, the population from Hail come to Eastern Province, Eastern Province to go to Jeddah, and Jeddah to Riyadh. So, there is heterogeneity of the races. So it's not like per region, okay, because people keep changing. At 5 to 10 years ago, Eastern Province, Hail was in top actually of prevalence of obesity at that time, and then followed by Eastern Province and by Riyadh. And lately, for the past 2 years or 3 years, I did a study in 2020. Actually, High City is actually coming the third, and that's definitely there's some improvement. Definitely improved, and the Eastern Province, or my place, actually getting the number one, and Riyadh, and then Hail, and I think that is a credit going to the city, doing great job. And this meeting is actually one of the how you advocate for the lifestyle.
Definitely. Last question, and I'm going to use that question in my favor as a surgeon. With these medications, I've heard that these medications, they do have tolerance. Patient will develop tolerance with time, and sometimes patients would need a maintenance dose monthly just to keep up with the continuous weight loss and continuous suppression of appetite.
So
do you have any input about this?
Yeah. So this is a very important question. Remember, the definition of obesity is a chronic, progressive, relapsing disease. So it's a chronic disease. It's not like a flu. So it's a medication that you need to take it lifelong. So that's the even if you look for Saudi FDA label, they approved Saxenda and Mounjaro as a chronic weight loss medication. And once you remove your hand, it will start rebounding exactly like anything. Even bariatric surgery, they can regain weight. It can happen. So that's one thing. So it should be take lifelong. طبعا في هناك a lot of people they do just tapering. It's not a practice. Some people said no, take a small dose and maintain. Again, this is not studied. If you reach to the target, then you need to maintain. Just as you are treating diabetes and hypertension, you need to be on this medication lifelong. And then you mentioned about the what is called metabolic adaptation. that sometimes when you do, for example, exercise and diet, you reach to a certain limit, you cannot push your weight more than this, whatever you do. And this is called metabolic adaptation. You need something stronger or something that helps. And this medication can help. But again, it will plateau to a certain level. It cannot achieve more than this. And that you have to be realistic. If a patient comes to the clinic and BMI is 55, so this patient should be go to the bariatric surgery. I mean, we should be realistic. And the rule of endocrinologist is actually to tell the patient you are fit for diet and exercise, you are fit for diet, exercise, and medical therapy, you are fit for surgery. So that's very important.
Thank you, Dr. Wade. The next question is for Dr. Khalid Al-Matham. As you know, that sometimes we have this obsession with reading labels to understand what we are eating, and it's reaching a point that we micro-calculate these numbers. The next question is for what's your advice on reading dietary facts or labels on packaged food and bottles to avoid overconsumption of sodium? Do you think that this is a great habit to do, or should be with moderation to avoid obsession with the label reading?
So I think it's just a frequent question. I think what I usually advise my patient is that you have to take a healthy, balanced diet. So obsession, like going to the extreme, either that I will measure it by the millimeters or milliequivalent, it's difficult sometimes. What I say is that try to avoid the canned food as much as you can because it's full of sodium regardless. And if we need, just try to you can read, but don't. And it's not going to be a lifestyle. It's going to be a huge commitment. So you will not be eating everything. You will be restricted to certain things. So usually I say try to avoid much of the canned food. Try to make a balance between the vegetables and fruits, and also the food that is cooked at home. Try to avoid food from outside unless it's necessary or like from time to time. This way the of sodium. Another misconcept that people think the salty food is that tastes salty, and actually if the food is normal, like it tastes normal, like everybody in the home they can take it, this is salty already. Okay, so if you have it doesn't have a good taste, that means it has less salt, and with time they will adapt to it. They can use substitute, for example, like I can put some lemon on that on top to give them the flavor. This way they can avoid excess of sodium. And from the study that we saw that the average diet is almost triple the daily requirement of sodium consumption.
Thank you. So lately we noticed that in supermarkets and places, when we buy water, there is an advertisement for 0% sodium bottles. And we want to shed some light. I for myself, I'm lost. Should I go for 0% sodium water or regular water? What's your input on this?
Yes, I'm not aware of any scientific evidence that low sodium in the water is different from the others. I think this is just what the company is trying to market their product. So I would say my advice is just to drink water. This is what the company. And what we suffer from here is that people don't. I drink from home, or should I buy the bottle 3 liters per day, and it's good, regardless of the source that you drink water from.
Okay, thank you, Dr. Khalid. Next question is for Dr. Mohammed Tanir. It's actually a long question. They're asking, was your study approved by an ethical committee? That's part one. Was it approved?
Yeah, sure.
Okay. The next question is, if yes, how did you manage to the need of a consent approval from a 15-year-old research group without parental approval? How did you convince the ethical committee to do that, to approve that?
Yeah. you know, usually this is what we call research risk, free research risks. This is a free research risk study. Yeah, any survey does not really initiate or bring any additional risk to the participants. So all what we take just their approval to participate in the study, and as you know, all information obtained from such a cross-sectional study will kept 100% confidential, and confidentiality is maintained 100%. So as I told you, in Saudi Arabia, usually if it is a clinical trial or if there is an investigational drug or additional risk during the study, parental approval with the approval. I mean, the child should sign an assent, what we call an assent from 6 years old. Like from 6 to 18 should sign also an assent. But in this kind of study, because it is free of risk and we consider 15, we lower the adult age to 15. So only his signature on the informed consent was obtained.
Okay, thank you. Next question is for Dr. Sami. Could you shed some light? And I'm sorry, maybe the question was written by autocorrect. Could you shed some light on the effect of using magnification on decreasing musculoskeletal disorders?
Well, if we're using that, we call it loops.
Okay.
That will help to reduce those problems. I mean, like if you're sitting in an upright position, wearing that loops, you can see indirect vision to see like clearly the whole tooth. I mean, like to help your sitting when you're sitting in the right position on that.
So next question, for you, Dr. Sami, how can we deal with meals for children which have problems with their teeth?
Well, starting with prevention. I mean, like give them a good diet. I'm not a nutrition, but we have to avoid them to eat a lot of carbs. And actually, you have to visit your dentist when you have like a child with first in teeth to prevent any caries lesion or cavities. So starting with that, like you have to manage like the diet by reducing carbs, increase foods. I mean, like watch them. They have to apply fluoride to avoid any future problems. I mean, like as a child, to reduce any future problems. I don't know.
So these are the questions that we can take in our limited time. Thank you very much for all speakers. Such a great session. Thank you.
Thank you.
Thank you, our moderator, speakers, for the informative session. Now it's the time for honoring our speakers. Dr. Sami المحافر, Dr. محمد, Dr. وليد البكر, and thank you, Dr. Khalid. Now Dr. Yusuf will join us to honoring our moderator, Dr. Rakan Al-Atemi. Thank you, our moderators, speakers, and audience. We hope that you benefited and enjoy in this session. Now we will move to the research session with Dr. Marwa Abdel Samad.
Good afternoon. It is an honor today to be the moderator of the research session. It is the last session in the conference. It is the last session in the last day of the conference. It is a good chance to be the moderator of the first session in the first day, and then the last session in the last day. Our session today will be related to the research committee in the conference. Let me talk as the chairman of the research scientific committee in the conference. I will explain some our work. I would like to talk about our work in the couple of weeks or couple of months before the conference. After call of abstract, the committee received around 75 research. After we review these all researches, we select about the top 20. The review process was by very excellent and very expert committee. The review process was according to guidelines and a standard checklist. Then the committee chose the top 20 abstract. This abstract, we try to make it bilingual, Arabic and English version. This top 20, put it in the screen in the corner of the researches, as you see before. Everyone can read in Arabic or in English, because our aim to let the community also explore what is going on in the research. So we try to translate all the researches also to be in English and to be in Arabic. And now the committee choose top 5 researchers or top 5 abstract. And now this session, the top abstract, top 5 abstract, will present their researches, and there is a committee, another committee now, will, after this presentation, they inshallah will select the top 3. The top 3 will be honoring in the stage, inshallah, today, and also we will honoring all the top 20 abstract. Thank you. Let me now represent the first presentation. The first presentation will be to Dr. Muhammad Ramadan. Let us welcome Dr. Muhammad. شكرا دكتور. One moment. Before, inshallah, Dr. Muhammad start, the committee, every presentation will talk about 7, maximum 10 minutes. After the presentation, the committee can ask the presenter or the author any questions. Then the evaluation of the all researchers will be after the all finishing of the all presentation for the top 5 abstract. Thank you.
Assalamu alaikum. Good afternoon, everyone. It's an honor and a pleasure to stand in front of you today to present our humble research project. So the title of my project is Prevalence and Factors Associated with the Poor Sleep Quality Among Visitors of Primary Healthcare Centers in Al Ahsa, Kingdom of Saudi Arabia. It's an analytic cross-sectional study. The first author is Dr. Abdullah Al-Bin Saleh, and I am the main supervisor of this research project. My name is Dr. Mohammed Ramadan. I'm the head of Population Health Management Unit in Al Ahsa Health Cluster. Starting with background. So sleep is a vital biological process associated with the human health and well-being. As we have seen over the last 5 days, sleep is one of the pillars of healthy lifestyle as well as lifestyle medicine. And by sleep quality, we cover various aspects of sleep, including sleep quality, including sleep time, sleep maintenance, sleep efficiency, sleep onset, latency, total wake-up time, and sleep disturbance like apnea and spontaneous arousal. Studies have shown that poor sleep quality is associated with a number of comorbidities, including, but not limited to, depression, poor cognition, obesity, type 2 diabetes, and cardiovascular disease. Not only that, it is also associated with increased risk of all-cause mortality. And it is a public health issue. Poor sleep quality is considered a public health issue, with the studies showing a prevalence ranging from 38.2 to 68% in the Middle East, including the Gulf countries, Europe, and Asia. That is like 1/3 to 2/3 of the population having poor sleep quality. And it is a costly issue. In the US, it is estimated that $411 billion are lost annually due to poor or insufficient sleep. Our study aims are to assess the prevalence of poor sleep quality, as well as to assess or evaluate factors associated with poor quality among visitors of primary health care centers in Alaska. Previous studies in the region were relatively old, and they did not consider all risk factors of poor sleep, especially with the advancement of the technology that we have seen over the last few years. Method. Our population are Alaska Health citizens, citizens as well as residents visiting primary health care centers. And our inclusion criteria include an age of 15 years and above. We have excluded pregnant ladies because pregnancy by itself is a risk factor for poor sleep quality. It is like unfair to compare pregnant ladies with the general public. Our sample was 461. We have calculated a sample size of 385 and using a formula. And we have added 20% just to compensate for incomplete questionnaires and so on. Sampling technique, we have randomly selected one PHC out of each of the 4 sectors PHC in Alaska. In Alaska, we have 4 health zones or health sectors. Among each sector, we have randomly selected one PHC. Then, when the time for data collection was conducted, the data collector have recruited participants based on systematic random sampling out of the booked appointments using a number generated by a dice to use it for the skipping among the booked appointments. For the data collection, we have used the face-to-face interview to fill the structured questionnaire. The questionnaire collects socio-demographic data, smoking status, caffeine, height, weight, and chronic diseases. And we have used a number of validated tools, including the Pittsburgh Sleep Quality Index for our study main outcome. We have used International Physical Activity Questionnaire, Patient Health Questionnaire to assess for depression, generalized anxiety disorder, perceived stress scale, and mobile-related sleep risk factors. All of those tools are validated tools, and they have been used in the Gulf countries before. This is the Pittsburgh Sleep Quality Index, and based on this scoring system, we have categorized our participants into those who have poor sleep and good sleep. Poor sleep has a score of 6 and more. The data collection was conducted between 22nd of January to 27th of February by 4 well-trained data collectors. And we have obtained the ethical approval for our research from the local institutional review board. We have used IBM SPSS to do the data analysis, and we have used appropriate univariate analysis test for univariate analysis and multivariate logistic regression analysis for further analysis of the association between the factors. Moving on to the results, we have recruited a sample of 433 participants, and we have found that 72.5% were identified as poor sleepers. They have poor quality sleep according to the Pittsburgh Sleep Quality Index. The age group that are most affected were the 18 to 28 years with a prevalence of 81.7%, followed by the age group between 29 to 39 years at a prevalence of 75.5%. Moving on to the demographic characteristic, and we have found an association between education and poor sleep quality. And we have found that people with lower level of education, that those who have finished elementary and less, were having less prevalence of poor sleep, less likely to have poor sleep compared to the other people who finish a higher level. This could be due to like less use of technology. Maybe those are like old people who are illiterate or did not finish primary school. Other demographic characteristics did not appear to be associated with poor sleep. And those characteristics include age, gender, nationality, marital status, residency location, occupation, and household income. Moving on to the lifestyle characteristics, up to 10 minutes, please. Yeah. We have found an association between caffeine intake and poor sleep, with those who consume caffeine closer to bedtime having higher prevalence. Other lifestyle characteristics did not appear to be significant, such as smoking and a number of cups of caffeine or physical activity and body mass index. For the mobile usage characteristic, we have found that there is association between the number of hours the participants use the mobile and poor sleep, as well as using sleep while you are in bed, going to sleep. There is higher prevalence of poor sleep quality among those who use the mobile on bed. Other factors related to mobile usage did not appear to be significant, such as keeping the mobile away from you or using silent or airplane mode. We have also found an association between chronic disease, the stress level, anxiety and depression with poor sleep. All of those increase the prevalence or the likelihood of poor sleep. We have put all those risk factors into multivariate logistic regression with stepwise backward elimination, and we have found that the most important risk factors include consuming caffeine before bedtime, using the mobile while in bed, and having symptoms suggestive of anxiety and depression. So our conclusion was that the prevalence of poor sleep quality is very high in our region, and the risk factor that is strongly associated with poor sleep include caffeine intake, using mobile at bedtime, anxiety, and depression. And thank you very much. Those are my reference, and thank you.
Thank you, Dr. Mohammed, for this valuable research. And now we have a few minutes for the evaluation from the committee. Any question from the committee?
Thank you, Dr. Mohammed, for a nice presentation about this good research. You mentioned in your research, I want to be clarify 2 points. You mentioned about the comorbidities with the sleep quality there is depression. How they assess the depression?
We use a screening tool, the patient health questionnaire tool, just for screening to see if the patient has symptoms suggestive of depression. So we cannot say that the patient have depression, but positive screening result.
Okay. And the second question about the age of the study group, you mentioned if age of 15 years and above. And during the duration of your research, what about do you consider the exam for the student there? Because usually for during the exam there is a stress and decrease the sleep quality.
True.
Yeah.
Yeah, true. We thought of excluding students in this research project to prepare for another project for the students specifically, for the young people, because we want to know what is the effect of social media and screen time on the students per se.
Okay, thank you.
You're welcome.
Assalamu alaikum. Thank you, Dr. Muhammad, for your great research. As you mentioned, you have the zone in Al-Hasa mini BHC. Can I know what is the zone for how many BHC it's related to the zone?
On average, we have about 15 BHC per zone, and we have 4 zones. So we totaled around 62 BHCs in Al-Hasa.
You are take all the 15?
No. Actually, we have randomly selected 1 BHC out of each zone.
And as you mentioned, you have 6 questionnaire you use it?
6 validated tools in the same questionnaire.
Can I know the Cronbach alpha for that?
I have it, but out of my mind, I believe that the percentage was around 80 something.
Okay, thank you, sir.
You're welcome.
Thank you so much, Dr. Muhammad. I will give you 7 out of 10. So to increase my rate for you, it has to be implementation research. What kind of, you manage to dissect the problem and you manage to know the result. So what is the planning? Is there any planning for referral or further, health services? Because in the end, it has to be the implementation research. So what is the plan?
Sure. Our recommendations out of this research, very briefly, is to raise the awareness of the public about the importance of sleep and how to improve sleep, giving them advice about sleep hygiene. Also, we will advise the healthcare providers to pick up people with poor sleep or factors that can affect poor sleep quality, to advise them and follow them up. And one of our recommendations also is to encourage researchers to explore possible interventions and implement those interventions and measure their possible impacts.
Thank you, Dr. Muhammad, for your excellent research. And I have actually 2 questions. The first one regarding the inclusion and exclusion criteria, and you mentioned that you exclude pregnancy from your sample size.
Mm-hmm.
And you mentioned the chronic patients were included in your research and sample size, although some chronic disease affecting the sleep like COPD, heart failure, so did you include all the chronic patients in your study?
We have included all those who we have picked during the systematic random sample, whatever disease he had. We did inquire about all the possible chronic diseases and like common prevalent chronic diseases in our questionnaire. But we may miss many patients with severe conditions that they don't follow in the PHC. So we should be cautious about generalizing our sample. We can say that our sample or study is generalizable at the level of visitors of the PHC.
And did you have further analysis for which chronic disease mostly affected the sleep?
No, actually, we didn't dig deeper, which is a good point that probably we should do it in the future.
Thank you so much.
It's a pleasure.
السلام عليكم حياك الله دكتور رمضان. I think your study exemplifies the good research methodology. I was very pleased to hear you today, starting from the objective, the sampling method, sample size. I have no remark whatsoever regarding your research, and I think that Dr. Mubashir asked my question: what are you planning to do with this 72% of poor sleep? What are the upcoming steps? That was my question, but I think that...
I'd like just to add one point that I have discussed it with sleep specialist. And we thought of generalizing our study to make it as much as possible national-wide, so that we can think of a pathway specifically for sleep for the future. I'm sorry for disturbing you.
Thank you, Dr. Mohammed, for this valuable research and this valuable discussion with our evaluator. And now, thank you. Good luck, Dr. Mohammed. And now, we will let me represent Ms. Asma Khalaf Shamari. It will represent her abstract now. Welcome, Asma.
Assalamu alaikum. Good afternoon to see all here and to meet incredible people from all subspecialty gathered to here today here for one purpose. My name is Asma Ramal. I'm a senior specialist health informatics. Currently, I'm working at حائل Health Cluster. Today, I will be presenting to you technology-driven solution for enhancing the quality of life and increase life expectancy, a case study in حائل City. So this proposal, a comprehensive strategy, utilizing the technology to increase the quality of life and elevate life expectancy in حائل City, targeting an increase from 74 to 18 years. So we conduct as pre-assessment in this study comprises 5 key phases. The first one, need assessment phases. Conduct survey and interviews with stakeholder and analysis existing healthcare infrastructure and challenges of حائل City, and collaborate with locally healthcare provider, government agency, and community. Secondly, technology evaluation and selection. Evaluate existing platform solutions to identify most sustainable technology for حائل City. Consider factors such as cost effectiveness, selection technology solution, in terms of the needs of حائل City. And if third phases, pilot implementation, design pilot program addressing healthcare challenge specific to حائل City. Collaborate to implement pilot project, monitor and evaluate pilot program. The fourth phases, stakeholder engagement. Engage the stakeholder through it, the implementation process, foster partnership and collaboration. Finally, phases, continue improvement, gather feedback from stakeholder and participant, iterate on pilot program based on الفيدباك والbest practice. Develop a roadmap for cycling successfully intervention across حائل city. Conclusion, by employing in this systematic methodology, leveraging the technology to enhance the quality of life and increase life expectancy in حائل city. Through collaborative efforts and innovative approach, we can address the healthcare challenge, empower individuals to adapt healthy lifestyle, and build resilient healthcare ecosystem to promote life expectancy and well-being for all residents of حائل city. Thank you for listening.
Thank you, Ms. Asma, for this, for your research work, and we wish you good luck. And now we can hear from the committee.
Thank you, Asma, for nice presentation. My question, do you review any previous research, the same title?
Yes, in صحة virtual hospital في عينات كثيرة على هذه التقنيات الحديثة اللي موجودة. يعني احنا في تجمع حائل الصحي في تعاون بيننا وبين مستشفى صحة الافتراضي في بعض التقنيات اللي تكون فيرتشوال مثل التليميديسن، برضو اللي هو الابوينتمنت في البلاتفورم تبع صحتي اب. هذه هي التكنولوجيا اللي موجودة. احنا راح نسوي لها بري اسسمنت ونشوف مدى فعاليتها ارتباطا في اللي هو الانهانس كواليتي اوف لايف والانكريز لايف اكسبكتنسي.
اوكي، يعطيك العافيه اسماء.
الله يعافيك.
اسماء، لو تبي تعيدين الاستدي والريبيت ات اجين، وات يو ويل دو؟
الستدي از بروبوزل جاست، يعني هي مقترح راح نقدمه للتجمع والمستشفيات اللي المين هوسبيتالز هنا، ونشوف ايش التقنيه المستخدمه يعني، ونسوي لها بري اسسمنت. ممكن الدراسه يعني تاخذ معنا سنه، بحيث انه يصير فيها تقييم وسلكشن وفيه بايلوت امبلمنتيشن، وبعد ذلك نقيس النتائج.
يعطيك العافيه.
الله يعافيك.
No more question, Ms. Asma.
Thank
we
you.
Good you. We wish you good luck. Thank you. And now we will introduce the third presentation for Dr. Syed Amir Ashraf. Welcome, Dr. Syed. By the way, Dr. Syed honored the last year as the best researcher in Hail conference. He have a good history of the conference.
Assalamu alaikum to all. A very good afternoon to all the dignitaries and the researchers present over here. Firstly, I would like to thank all the organizers, panelists, and convener of this conference for providing me the opportunities to present my research work in front of you all. Actually, my title for the presentation is Production and Development of Novel Biopolymer, which is derived from Albamoscus esculentus. And we checked its anti-diabetic potential, and this is a source of food. So we try to develop a nutraceutical from this extracts. This research work was done by the team members of Clinical Nutrition Department, and the research was funded by University Research-Dinship, University of Hail. And as a food professional here, what actually we were looking to investigate the advanced utilization of food bioactive components and its role in the management of metabolic disease such as diabetes. So we all know that diabetes is a metabolic disorders, okay, which is characterized by hyperglycemia. And when there is a hyperglycemia, it means that there is a problem either in the insufficiency of insulin, or there is a decrease in secretion of insulin, or there is some metabolic processes. Either actually, this diabetes is categorized majorly into two portions. One is, we can say, type 1 and type 2s. Around the world, that we have 90% of the population which has type 2 diabetes, and 5 to 10% they have autoimmune disorder that we can have the type 1 diabetes. Here what happened, the incidences of diabetes is rising as a result of changing in lifestyle activities, changing in eating habits, changing in the living circumstances. And all these scenario has put into a development of this type 2 diabetes. And what is problem with that it is creating a lot of healthcare cost to the patients or to the persons. So if you see there is a data which suggests that, which was published by International Diabetes Federation in 2021, which suggests that around 537 million people, they are living with the diabetes around the globes. And they are predicting or projecting that by the end, when we will be reaching to 2030s, it is going to be more than 643 million people. So this is a very huge population which will be going to suffering from diabetes. And if you see the Saudi Arabia, which has been ranked according to the IDFA under the MENA group, that is called Middle East North African regions. And if you see from the chart, it is increasing every 5 years from 2021, which was 73 million, and it is projected to increase to 95 million, and in 2045, it is 136 million, which is very huge number. And in this MENA region, the percentage of diabetes is increasing by 87%. If you see the IDF report, this is the second most highest where the diabetes is going very high. Now, in Saudi Arabia, as per the report, they says that around 17% populations are living with this diabetes, and which is again a huge quantity or huge number. And ultimately, it is posing a very risk to the patients. It causes mortality, it causes the health risk and huge healthcare cost in that. So as a food scientist, what we are looking to introduce are natural ways to prevent or manage the diabetes, rather than going for injection, going for some type of medicine, going for some type of different type of treatments. So there is a very common vegetable you might be aware, that is called Abelmoschus esculentus, which is also called bamia in Arabic, and the other names that are lady's fingers and green ginseng. It has a very nutritive values in terms of eating behavior, but at the same time, it has some phytochemical compounds, which is very essential for different purposes. Now, our main objective in this project designing was to use the mucilage which is secreted through this okra, because this is actually a polysaccharide compound, and this can be utilized for the management. And based upon that, actually, we designed this research. So just quickly, I will go here to this slide. This was our objective. We developed this okra. From the okra mucilage, we developed novel biopolymers, and then we characterized this polymer by using the FTI analysis. Then we perform some activity like how much the percentage yield, solubility, and swelling index. And then we check for in vitro assays for alpha amylase and alpha glucosidase activities. In methodology, we perform the extraction of okra mucilage. Actually, we take a fresh okra and then we chopped it and soaked into the aqueous solution for overnight for 12 hours. After that, we strained with the liquid fraction with the muslin cloth, and then by adding triple volume of alcohol, we segregated the precipitate. And that precipitate we dry in the hot air oven for 30 degrees at 12 hours. Then we get the polymer from there. And this polymer, actually, we perform for characterization by using this FTIR machine. This FTIR actually used for functional group characterization. If we have any raw material, so we can check the functional group identity of that type of any type of raw material. So we use this FTI technology. Then we perform some physiochemical properties, then in vitro studies. Coming to the results. So based upon the FTIR analysis, we found that although these polysaccharides, the mucilage, what we prepare as a biopolymer, this was a polysaccharide, but this polysaccharide was, when we see the spectra, this is the spectra of FTIR, so the results was between 3,000 to 1,000. So this indicate that this is the polysaccharide fingerprinting regions. So it indicates that although it has polysaccharide, but it was not related to the cellulose and starch which contribute in the glucose increase. So it has some few functional band indicated the presence of peptides cross-linking along with some amino sugars. Now coming to the yields. So when we do the extractions, when we do the precipitations of this biopolymer, we got around 2.6% the polymer of this ochra mucilage. And then the solubility, it was very much soluble with the warm water compared to the other organic solvent or the cold waters. Now on the anti-diabetic activity, we performed these two assays and we found that in both scenarios, whether it is alpha amylase or alpha glucosidase activity, both were the concentration dependent. Means we had when we were increasing the concentration of our polymers, so there was an increase in inhibition of the alpha amylase and these glucosidase. As we know that these two enzymes are very essential in metabolizing the carbohydrates, because what happened when we have the carbohydrate, when we eat the carbohydrate, so it metabolizes and increase the postprandial glucose level in our blood streams. So this blood stream, by applying or by utilizing this mucilage biopolymer, we can delay the processing of increasing the blood glucose level in blood stream. So this is our actually main motto for this result. So in conclusion, we can say that FTIR has revealed that polysaccharide was the major components of, as per FTIR analysis, galactose, rhamnose, and galactorinic acids. And the other important note about this biopolymer, that nowadays we are going for nanotechnological streams. In nanotechnological stream, we use different type of chemicals to carry some medicines. But these biopolymer which we developed by using the mucilage can be utilized in future for the carrier of any type of medicine. It can also be used as an edible polymer. Nowadays, there are various food industry, they are applying wax and other chemicals to make it shiny, to make it more permeable. But these polymer can be edible and it can be very useful in futures. So therefore, we conclude that the novel ochra mucilage biopolymer could become an important natural source for food, pharmaceutical, and nutraceutical applications. So thank you so much. If you have, these are the references. And thank you so much. If you have any questions, please.
Thank you, Dr. Said, for this great research work. And now we will hear from our committee. Please, quickly.
Only one question. Thank you, Sayyid Amir, for informative presentation. I think you are interested in the okra too much. My question about the okra is a challenge study, really. How the participant take the okra? What is the way of
Actually, here we did not use any participant. Here we just prepare a novel biopolymer, which was derived from the mucilage of okra. So this is the first stage of our studies.
But sorry for interrupting.
Yes.
What is the plan? How to be given?
Yes, actually our plan is whatever the polymer we have, that we will try to give either first. There are stages in the research. We cannot directly give it to the humans. So there are some stages. We will follow that direction, and based upon that, we will go for the human beings. We cannot directly, because these polymers we are planning to use as a nutraceutical products, not as a medicine. So it will help to delay the blood glucose if somebody has already diabetes and if he has some eating, if they take some 2-3 spoons of these nutraceuticals, it may delay the carbohydrate metabolism and it will not increase the level of glucose in a quick succession.
Thank you so much. In Sudan, a lot of, areas they are using okra, bamia, like on daily basis. So they use this in the dinner as well as in the breakfast. So also I do recommend for you to do like some studies with like to measure the glucose level after eating this, and they're using this for the kids. So also for the pre-diabetic. So this is one of the areas it can be for the intervention. I like your research.
Thank you so much.
Also, I like okra.
Thank you so much.
Thank you, Doctor, for being here. And we are happy to hear that in Hail University, we develop such advanced and practical research. So a small question, if the active the component studied is deteriorated depending on the method of cooking, if you know that, we'd like your advice. So what's the best way to cook okra to get the best benefit? This is my question, if you know that.
Definitely, because these are the polysaccharides. So if we cook at high temperature, so there is a more chances that it will break down into the simpler disaccharide or monosaccharides. So there is a more chances it will come. But our objective was to utilize the mucilage in a separate way, not to mix with this. So this is main objective for these studies. Okay, thank you.
Thank you, Dr. Said, for this valuable session, and thank you for this valuable discussion from our reviewer. And now we will go to the fourth presentation. Now the presentation for the abstract of Dr. Marwa Saad and Dr. Rana Amara. It will be presented by Dr. Rana. Welcome, Dr. Rana.
Assalamu alaikum wa rahmatullahi wa barakatuh. I am presenting the research which is conjoint with Dr. Marwa Ahmed Saad. She is the principal investigator, professor of internal and geriatric medicine in Faculty of Medicine, Alexandria University. And the topic of research is the role of myostatin as a potential diagnostic biomarker in elderly patients with sarcopenia. And as we all know, sarcopenia is a problem with age, and it is characterized by a progressive and generalized loss of both the skeletal muscle mass and the strength. And sarcopenia causes poor quality of life, increased mortality in patients. We use the European Work Group study of older people 2019 criteria to assess both the muscle strength and the muscle mass for diagnosing sarcopenia. And actually the sarcopenia is multifactorial, maybe because of the lack of physical activity. It may be due to age-related changes in the hormonal and the cytokine imbalance. People who are older, they have low growth hormone, low testosterone, low thyroid function, and low insulin growth factor. And definitely nutrition plays a role in the development of sarcopenia through insufficient caloric and protein intake. Actually, sarcopenia assessment is very troublesome because there are many methods to assess the muscle mass and the muscle strength. First of all, we can use the bioelectric impedance analysis, the one that we use to estimate the body composition analysis, but maybe it's not that sensitive. CT and MRI also can be used to assess the muscle mass. DEXA scan, as the same as osteoporosis, we do it for osteoporosis. We can also detect the muscle mass, and simply we can do muscle circumferences like calf muscles and the mid-arm muscle circumference. For muscle function, we use tests that the patient should do, like the walking, the gait speed test and the chair rise test. And for the muscle performance, we use the hand grip strength. So as you see, there are multiple components to just diagnose sarcopenia. So this is why we are searching for a single laboratory investigation that might be helpful for diagnosing sarcopenia, which is the myostatin. Myostatin is a myokine, and its main role that it suppresses skeletal muscle protein synthesis, and the inhibition of myostatin may be a potential promising way to reverse the sarcopenia, and research has shown also that it can help in muscle regeneration in muscular dystrophy disease. Our aim is to evaluate the accuracy of serum myostatin in prediction of sarcopenia in elderly and its correlation with quality of life in patients. We did a case control study using 64 elderly, 2 groups, 32 sarcopenic patients diagnosed based on the EWG SOP2 definition, and 32 matched for age and gender as served as our control. We recruited our patients from the Alexandria Main University Hospital and the General Navy Hospital. We excluded chronic renal, hepatic patients, chronic heart failure, diabetes, and postmenopausal women on hormonal replacement therapy. We did anthropometric measurements, including weight, height, BMI, and waist circumference, and we used the BIA, the bioelectric impedance, to assess the appendicular skeletal muscle mass index, which is the total of the muscle mass in the 4 limbs divided by the height square, and we use the cutoff limit for sarcopenia, which is 7 kilogram per meter square for men and 5.5 kilogram for women. And for muscle strength, we used the dynamometry. The hand grip strength was used, and the cutoff point was less than 27 kilogram for both sexes. And about the performance, we used the gait speed, in which the patient was instructed to walk for 3 meters, and he should be walking in the speed of 0.8 meters per second. If less than this, so he has low performance. We also used the short form 36 health survey questionnaire to evaluate the quality of life of the patient regarding emotional, mental, physical functioning. We also did laboratory investigations, the routine lab investigations, and we actually used myostatin. It's not found in labs. It's only for research by an ELISA technique. This is our results. So the sarcopenic patients had significantly lower weight compared to our controls. They also had significantly lower appendicular skeletal mass index and hand grip strength using the dynamometry, and also physical performance, which is the gait speed. They had also a significantly higher serum myostatin compared to the control, and they showed a lower score in the short form 36 questionnaire compared to the control. And as we see here, there is a significant negative correlation between the serum myostatin and the short form 36 survey compared to the control groups. Using the ROC curve test, we have found that the cutoff point for myostatin that can separate or can diagnose sarcopenic from non-sarcopenic patient is 29, and it showed 87.5% sensitivity and 75% specificity, which is high sensitivity and specificity. So my conclusion is that serum myostatin is a possible blood-based biomarker for prediction of sarcopenia, as well as quality of life assessment in elder. And of course, we need further research with larger sample size to confirm our results. And thank you all.
Thank you, Dr. Rana, for this valuable presentation and knowledgeable work. And then now for the questions, please.
Thank you, Dr. Marwa, for a nice presentation about sarcopenia. Okay. So about, the sarcopenia is also affected by some drug. About the selected group, do you exclude the
diabetics excluded?
Any patient, anyone with on a drug? Do you exclude?
Yes, we excluded chronic renal failure with CKD, diabetic. Of course, diabetes is one of the main causes of sarcopenia, so we excluded diabetics also.
Okay.
Thank you, Dr. Rana, for your nice presentation. Can I know the inclusion and exclusion criteria?
The inclusion is anyone who is above 65 years old, and then we have divided them into two groups, the cases and the controls, based on the European Working Group for OSP. And we have excluded patients with other chronic diseases that might interfere or might cause sarcopenia, like females on hormonal replacement therapy, chronic kidney diseases, diabetes on drugs.
Thank you.
شكرا دكتورة رنا. Straightforward, very important research. What is your plan of intervention?
Well, because as clinicians, you don't have the time, maybe you don't have the equipment, and maybe you don't have the trained personnel to assess sarcopenia. And especially if you have a patient who is sarcopenic obese, he looks fine. He is obese. So how can he be sarcopenic? So maybe using a laboratory biomarker can save time and give the clinician a clue about that this patient might be subjected to sarcopenia later on.
Assalamu alaikum. Great work, Dr.
you.
Rana. A simple question. Is there any gold standard for the diagnosis of sarcopenia to compare your specificity and sensitivity?
It's still, well, because this is it's the first time, it's not really, it's not a guideline to be used, but when we use the statistical analysis of the ROC curve, we found that it has a high sensitivity and specificity. So maybe it can be used, but there is no specific guideline. There is only research still up and now.
Good job. Thank you.
Any question? Thank you, Dr. Rana, for this valuable discussion. Good luck. And let's now move to the last presentation for the research session today. Let me introduce Mr. Saoud Al-Oreithi. Saoud is a student in Haiel University, but he has a great job. Let's welcome Saoud.
Assalamu alaikum wa rahmatullahi wa barakatuh. Hello everyone, and thank you all for coming today. I'm Saoud Al-Oreithi, and today I'll be representing the integrated molecular docking, molecular simulation, and in vitro validation revealed the bioactive components in soy fermented food and their underlying mechanistic pathway in lung cancer. Today, I would like to start with the question, have you ever wondered if there could be a simple, everyday food that holds the key to cancer prevention? Today, we will explore the fascinating world of soy fermented foods and their potential in combating lung cancer. Together, we will go through 4 key sections: an introduction into the significance of lung cancer and the role of bioactive components in soy fermented foods, viewing the methods employed to investigate and the effects of these bioactive components on lung cancer cells, discovering the result and finding that shed light on the potential preventative properties of soy fermented foods against lung cancer, and the conclusion. Millions of people around the world suffer from lung cancer by showing symptoms like coughing, chest pain, shortness of breath, and coughing up blood. So, looking into the complication of lung cancer as it starts in the cells of the lungs, spreading into the brain, liver, bones, and adrenal glands. It is also reported as the second most common cancer in the world, and by 2020, it is expected to have more than 2.2 million new cases and 1.8 deaths. In recent years, treatments were developed for lung cancer, and it is estimated that only 1/3 of cancer patients can be cured by these treatments. Various treatments can lead to major side effects and even higher costs. As a result, it is necessary for the development and finding of a new medicine derived from natural sources, particularly plant-based functional foods, in order to ensure these drugs are abundantly available as well as relatively cheaper in price. In this context, soy fermented foods emerge as a promising avenue of cancer prevention. They are made from soybeans that have undergone a process of fermentation by microorganisms, being rich in protein, fiber, phytochemicals, vitamins, minerals, and probiotics. Soy fermented foods may prevent or treat some chronic diseases. There are several components in soybean fermented foods that have anti-cancer properties, but the most prominent compounds are isoflavones, which are powerful antioxidants that can shield human cells from oxidative stress that can lead to cancer. In the study, will shed light into the possible mechanism of action of multifaceted bioactive substance by using reverse pharmacology approaches to identify possible protein target, as well as to investigate the basic anti-cancer and anti-metastasis activities. Now that we have established the significance of soy fermented foods in cancer prevention, let's delve into the methodology employed to uncover their potential. Firstly, we began by identifying the potential targets of bioactive compounds found in soy fermented foods and their relevance to lung cancer using comprehensive PubChem database. We constructed and investigated protein ligand interaction network using the resources of the string database. This allowed us to elucidate key interactions and pathways involved in cancer prevention. Moving on, molecular docking analysis was employed to explore the binding interactions between the bioactive compounds and their target proteins implicated in lung cancer. Subsequently, molecular dynamic simulation were conducted to further validate and refine our findings. Lastly, to assess the biological activity of the compounds, we utilized the MTT assay, a standard method for evaluating cell viability and proliferation. Now let's delve into the exciting result of the study. Through our analysis, we identified 6 major isoflavones present in various soy fermented foods. Among these, diazine emerged as particularly noteworthy, exhibiting the highest potential in binding affinities within lung cancer cells, as shown in this figure. As illustrated here also in the figure, the dynamic nature of the protein ligand complex reveals fluctuation in their binding affinity and structural conformation throughout the simulation period. As depicted in the figure, our experiments revealed the significance of inhibition of lung cancer cell viability in response to diazine treatment across various concentrations. The dose-dependent response underscored the potent cytotoxic effects of diazine on lung cancer cells, highlighting its potential as a therapeutic agent against lung cancer. As shown in the figure, this observation suggests that diazine not only inhibits lung cancer cell proliferation, but also hampers their ability to migrate, which is crucial for cancer metastasis. These results underscore the multifaceted anti-cancer effects of diazine and its potential in embedding the spread of lung cancer cells. In conclusion, our study underscores the promising therapeutic potential of soy fermented foods in lung cancer management. By exploring the effects of bioactive components like diazine, we have uncovered valuable insight that pave the way for novel approaches to cancer management. Thank you all for attention and engagement throughout this presentation. I would like to extend my sincere appreciation for the organizers of this conference for providing such an amazing opportunity for us to share the research. Thank you.
Thank you, Mr. Saud, for this great job. And now we can hear from the evaluator if there is any question.
I don't have any question. Thank you, Mr. Saud. I'm happy, and this is a really good starting in the research while you are a student.
Inshallah.
Good luck. Thank you.
Thank you for your presentation. بس كلمة تشجيعية، الله يعطيك العافية. الله يعطيك العافية، وإن شاء الله نشوفك مستقبلا إن شاء الله كبريزنتر في اللايف ستايل ميديسين كونفرنس انترناشونال كونفرنس. Thank you.
شكرا.
Thank you, Saud, for this presentation and for the discussion. And now the evaluatory committee will meet together and discuss to let us know who will be the best presentation and who will be the first and second and third. And they will be nominated and honoring now. After 5 minutes, we know who is the best research in the حائل International Conference 2024. Please wait this exciting moment, inshallah. thank you for your patience, for waiting the result. And now the most exciting moment today, to nominate the best 3 abstract in حائل International Conference 2024. Let us invite Mr. ناصر أبو ناصر سلطان مساعد. اتفضل حضرتك. ودكتور مشعل رئيس اللجنة العلمية ومدير عام الشؤون الصحية بحائل لتكريم الفائزين ال3. إن شاء الله. تمام. هنعلن الأول المركز الثالث النهارده في أحسن بحث، أحسن بحوث مقدمة. المركز الثالث تتوقعوا مين؟ المركز الثالث حصل عليه سعود العريفي، طالب بجامعة حائل. احنا حقيقي فخورين بالريسيرش بتاعه والشغل بتاعه، كونه طالب بصراحة يستحق التقدير. ألف مبروك سعود، وإن شاء الله نتمنى يكون معانا في النسخ القادمة إن شاء الله من المؤتمر. دلوقتي هنعلن المركز الثاني. برضو كلنا نتساءل مين أخذ المركز الثاني. بصراحة كل الأبحاث اللي قدمت النهاردة كانت توب، يعني وكان في صعوبة من اللجنة إنها تختار who is the best. حصل على المركز الثاني بحث الدكتورة مروة سعد والدكتورة رنا عمارة من مصر. ألف مبروك دكتور رنا. ألف مبروك دكتورة رنا وألف مبروك سعود. دلوقتي the most exciting moment for the first place of the best research today for حائل International Conference. It will be awarded to محمد جاسم الرمضان. All the committee nominate Dr. Muhammad for the best abstracts for this year. Thank you. نشكر مدير عام الشؤون الصحية لدعمه بصراحة العلمي لكل البرنامج العلمي وخصوصا الأبحاث. ممكن نسمع من حضرتك كلمة بسيطة.
السلام عليكم ورحمة الله وبركاته. حقيقة أنا فخور بما رأيت اليوم من أبحاث، وأبارك لكم قبل نفسي وقبل زملائي اختتام هذا المؤتمر بهذا اليوم وبهذا الشكل المميز. شكرا للجميع، شكرا لمن شارك، شكرا لمن تحدث، شكرا لمن أثرانا في هذا المؤتمر العلمي، شكرا لفريق العمل زملائي الدكتور مشعل وجميع فريق عمله على هذا الإبداع وعلى هذا الإخراج الجميل. الحقيقة البحوث جميعها أثرية. المعلومات التي أو اللي فيها جميعها إن شاء الله تعالى نتوقع بإذن الله تعالى أن يكون لها مخرجات بإذن الله وصدى يعود النفع بها للوطن والمواطن. شكرا للجميع وأبارك للثلاث بحوث الفائزة، وأيضا البحوث التي لم يحالفها الحظ هي بحوث بإذن الله تعالى أنها من البحوث التي سيعود نفعها إلى الوطن والمواطن. شكرا لكم جميعا وحياكم الله.
استاذنك من وقتك دقائق نكرم بقيه المشتركين معانا في البيست 20 ابستراكت، لان هم برضو كانوا ابحاث ما شاء الله عليهم، يعني كان جود جوب. وزي ما قلت لكم ان احنا اخترناهم من 75 ابستراكت. هنكرم دلوقتي let's honoring اسماء خلف الشمري for her good job in research. Let's also to honoring Dr. Saeed Amir Ashraf for her good job in research. The next one for the best 20 abstract, Mustafa Ahmed Muhammad Ahmed. Next.
اللي بعده سعيد طامي.
دكتور سعيد طامي سعيد اليامي. دكتور محمد سامي العريفي. نيكست. سعيد.
هلا وسهلا. كل جهودك. ما شاء الله.
وعليكم السلام. دكتور سعيد. دكتور فخر الدين. دكتور فخر الدين.
ما شاء الله يستاهلون.
Research group from حائل cluster. دكتور رائد مساعد العنزي. This also a group research from حائل University. They are students. The future of the research is promising in حائل University إن شاء الله. Okay, بنات. بيان زمان الشمري. شكرا لطلبة جامعة حائل اللي كان لهم مشاركة جيدة جدا معانا. بيان زمان الشمري وجروب الأبحاث معاها. طلبة من جامعة حائل أيضا. شكرا جروب أسماء. دكتور سعد الصالح. دكتور سعد. Let's welcome Dr. Saad. الدكتورة شهيدة. بروف دكتورة شهيدة من جامعة حائل برضو. اتفضلي. نيكست مس هيا فهد عقيل العديلي. هيا هي برضو graduated from حائل University. حائل كانت طالبتي. اتفضلي. next دكتور محمد المنصور إذا كان موجود. دكتور محمد من خارج حائل، إن شاء الله نوصله شهادة. نريمان أديب الشيخ. دكتورة نريمان مش موجودة. دكتور سميرة مسعود لو موجودة. هم الدكاترة دول من خارج حائل، ممكن هنوصل لهم، بس يعني فور اونرينج هنذكر الاسماء بتاعتهم ان هم اشتركوا معانا. عبد العزيز سلطان الانكاري. دكتور غانم الخطابي طبعا من مكة، واستلموا مندوب عنه يوصله له لمكة كلاستر. ثانك يو مستر سلطان. ثانك يو فور سو ماتش. With it is honoring to be the last session before the closing with Dr. Mishal Nais, the chairman of the scientific committee of Hail International Hospital. Let's welcome Dr. Mishal. ممكن ناخد يعني اظن انا مقيمين يصوروا معي.
اوكي.
طيب خلينا نصور.
يلا. Now we came to the end of our scientific program. This is the last day. Alhamdulillah على التمام. We enjoyed, we learned a lot of things from all the speakers and moderators. Now we will elaborate with you our recommendation, the conference recommendation 2024 recommendation. So can we start, or just they will take one photo? Okay. No, you can take the photo, and after that, because all the reviewer want to take a photo with the conference chair. Please, all the reviewer, scientific research reviewer, come to the stage, please. Dr. Yusuf Al-Jarallah, please. We need you here. Okay, thank you very much for the Dr. Marwa moderating research and all the reviewer for this valuable review. Now with the recommendation, actually this recommendation we elaborate for you. It's coming from different resources. We ask all the speakers coming to this conference, all the moderators and some audience to give us some hints and feedback, recommendation for the next year, inshallah, in the Lifestyle Medicine Conference in 2025. So I will take in Arabic and English, don't worry, we have a time. So I will start with the first recommendation in Arabic, which is okay. التوصية الأولى، وهذه توصيات علمية وليست توصيات المؤتمر ككل. توصيات المؤتمر ككل سوف تدرس عن طريق اللجنة العليا، ولكن نتشارك معكم اليوم هي توصيات اللجنة العلمية، وسوف إن شاء الله تطلق توصيات المؤتمر ككل في الأسبوع القادم بعد دراستها من اللجنة العليا المؤتمر ودراستها من جهات أخرى. لدينا في اللجنة العلمية أخذنا أغلب الفيدباك والتوصيات من جميع المتحدثين ورؤساء الجلسات والحضور ممن تفضلوا وقدموا لنا بعض النصائح وبعض التوصيات للعام القادم. أول توصية كانت هي العمل على إنهاء اتفاقية مع الكلية الأمريكية لطب نمط الحياة. مثل ما لاحظتوا احنا جانا زوار كثير من الكلية الأمريكية لطب نمط الحياة وتشاركوا معنا في العديد من المحاضرات، فكان من باب الأولى أن تستمر في التواصل معهم للاستفادة المتبادلة ما بين الكلية الأمريكية لطب نمط الحياة و وزارة الصحة أو الشؤون الصحية المديرية لمنطقة حائل أو صحة حائل بشكل عام. فهذه كانت من التوصيات القوية اللي جتنا من أكثر من شخص. التوصية الثانية وهي العمل على اتفاقيات مع الشركات الزراعية وشركات التغذية العضوية. من الكثير من المحاضرات التي ألقيت في هذا المؤتمر خلال 5 أيام هناك الحديث عن الأورجانيك فود والأكل العضوي، وأيضا تشجيع الشركات الزراعية، التعاون مع الشركات الزراعية والشركات التغذية، أنه يكون هناك توجه إلى الغذاء الصحي العضوي والخالي من المبيدات ومن المواد الكيميائية بقدر الإمكان. فهذه اتفاقية وأخذ توصيات العلماء والخبراء الذين شاركوا في مؤتمر طب نمط الحياة في حائل، إن شاء الله بإذن الله راح تكون بادرة خير بتحسين نوعية الأكل الموجود داخل الأسواق أو الغذاء أو الفواكه والخضار حسب ما أوصى فيه الخبراء والعلماء الذين تحدثوا معنا في هذا المؤتمر. فهي على هذه النقطة. I will repeat in English. The first recommendation was to do a collaboration and agreement with the American College of Lifestyle Medicine. You notice many speakers coming from United States with us here and this year, so we have to continue collaborate with them, and even with the UK Lifestyle Medicine Associations, whatever, where is a lifestyle medicine institutions, either associations or colleges, we will go for that, inshallah, all over the world, even in India or in UK, even in United States, whatever. There is a connection for lifestyle medicine or lifestyle changing, we will do on that. The second point with the recommendation, I will repeat it in English, to do agreement also with the companies, food companies, agriculture companies that will facilitate the organic food in the market instead of food with many chemicals and pesticides. So we will encourage all these companies, the local companies, to go with this organic food. And actually we have to watch the price, the cost. You know, the organic food, it's a little bit costly, so we will work on that to seek and to available to bring all this organic food available for public. ثالث نقطة هي تشجيع الأبحاث العلمية المتعلقة بطب نمط الحياة في جميع القطاعات الحكومية والخاصة والقطاع الغير ربحي في جميع محاوره. زي ما شفتم الأبحاث كانت جزء لا يتجزأ من مؤتمرات طب نمط الحياة، النسخة الأولى والثانية والثالثة. ولله الحمد هناك كثير من الأبحاث وكثير من الباحثين في منطقة حائل ومناطق المملكة التي يعني لمسنا منهم حب وتشجيع الأبحاث في هذا النطاق أو في هذه المحاور. بالنسبة لنا في المؤتمر احنا لا نقدر أننا يعني نستقبل الكثير ومئات من الأبحاث نظرا لضيق الوقت ونظرا لعدة عوامل، ولكن لو كان هناك كرسي أبحاث أو مركز أبحاث يتخصص، زي ما أنتم عارفين محاور طب نمط الحياة هي محاور كثيرة، منها التغذية والرياضة وطب النوم وإلى آخره. فمن الريكومنديشن والتوصيات هو تشجيع هذه الأبحاث في جميع القطاعات وليس فقط في صحة حائل. فإحنا نشجع وراح نعمل اتفاقيات ومذكرات تفاهم إن شاء الله بالقريب، وهذه يعني توصيات إلى العام القادم، وسوف نرى بإذن الله نتائج هذه التوصيات وفوائدها. كان في المؤتمر النسخة الأولى من ضمن التوصيات إنه الرياضة طبعاً وزيادة المماشي اللي في حائل، ولله الحمد زادت بشكل كبير، ويمكن كلكم تلاحظون بدعم سمو أمير المنطقة الأمير عبد العزيز بن سعد وزملائنا في الأمانة أيضاً ما قصروا ودعموا هذه النقطة، ولله الحمد الآن المشي كان صار أفضل والرياضة صارت أفضل، ولكن احنا نحتاج أن نروح شوي لما الأبحاث والغذاء وهذه النقاط. I will repeat in English the third point. It's the encouragement of the research, the lifestyle medicine research, whatever in the governmental sector and the private sector. So this is will do more data within Hail or whatever in the Kingdom of Saudi Arabia, and this for sure will lead to more education and more data, more background, more benchmarking in the lifestyle medicine in Saudi Arabia. Next. من التوصيات افتتاح عيادات متخصصة في طب نمط الحياة تشمل جميع محاور طب نمط الحياة تدار بممارسين صحيين حاصلين على بورد طب نمط الحياة. وهذه أيضا كل يوم من أيام المؤتمر كنا نشوف أحد سبيكر اللوكالي أو الانترناشنال ينصحون ويوصون في عمل عيادات متخصصة في طب نمط الحياة تدار بمتخصصين وكواليفايد بيرسون في جميع محاور وفي جميع طب نمط الحياة هو طب مالتي ديسيبلينري تيم، ومحاور ممكن أي شخص من الممارسين الصحيين يحصل على البورد، سواء كان نيرس أو فيزيوثيرابيست أو فيزيشن وفارماسيست whatever. He's just learning the board and to be certified in board and he can run a clinic. I will repeat in English. One of the recommendation is to open a clinic, lifestyle medicine practice clinic, and run by certified board staff. This is the fourth one. Next. Okay. النقطة اللي بعدها تحسين قائمة الطعام أو المواد المستخدمة بالغذاء الصحي في مقاصف، أو تحسين قائمة الطعام بالغذاء الصحي في مقاصف المدارس أو الكافتريات في الجامعات. أكيد كلكم تعانون من هالشيء هذا، وأكيد كلكم عندكم الله يصلحهم ويخليهم لكم أطفال وبأولى ابتدائي وثاني ابتدائي وثالث ابتدائي، وأنتم عارفين إيش الأكل اللي يباع في المقاصف. احنا في طب نمط الحياة نشجع من جانب التغذية الصحية، نشجع بتحسين وتعديل هذه القائمة، وإن شاء الله راح نعمل بإذن الله في القريب العاجل مع الجهات المعنية على تغيير، وخصوصا في الصفوف الأولية. أنتم عارفين يعني وقت النمو، يمكن دكتور يوسف يفيدنا بشيء، وقت النمو اللي هم أولى ثاني ثالث ابتدائي رابع ابتدائي، يعني لابد أنك تدعمه في الغذاء الصحي بحيث أنه يوصل إلى المتوسط والثانوي وهو نموه جيد طوله مناسب بعيدا عن هذا الأكل الغير صحي. I will repeat in English. The next point is to encourage to change the menu in the schools, especially preliminary schools, when the child growing and so if you concentrate in the school and even in the universities or high school, whatever, for me, I encourage to change all the menu in all level of education, even in the universities. But sometimes the university students you cannot control, but at least you can control the preliminary student when they grow. So you just change the menu, concentrate on the healthy food, minerals and cereals and whatever, milk and so on. And we will work in this. النقطة السادسة هي إدراج مناهج علمية تثقيفية في مناهج المدارس ابتداء من الصفوف الأولية عن جميع محاور طب نمط الحياة. كثير من الزملاء ومن الحضور ومن المودريتورز ومن السبيكر أعطونا النقطة هذه، وهي كانت يعني في البال أيضا بأنه ليش ما يكون في المناهج الصفوف الأولى في الأول ابتدائي وثاني ابتدائي تثقيف ما هو طب نمط الحياة، وهذه توصية راح ترفع إن شاء الله للجهات المعنية عشان يعرفوا إنه في تغذية صحية، في رياضة، في جوانب نفسية واجتماعية إلى آخره من محاور طب نمط الحياة. وإن شاء الله هذه أيضا، وزي ما تلاحظون إحنا مركزين على النشء الجديد والنشء الصغير، لأنه هو الفيوتشر وهو النكست جنريشن، وهو اللي ممكن تشتغل معه على الوقاية وليس الالدرلي. الالدرلي already they are sick on medications, and lifestyle medicine, it's concentrated on the prevention more than treatment. So I will repeat in English. The last one, it's to change the or to insert some information of the lifestyle medicine books and the preliminary school also for a child, to educate them for the lifestyle, what is the lifestyle medicine and what is the pillars of lifestyle medicine. Since they are small, at least not mandatory subject, at least it will be like optional or education. So this is will guarantee in the future that you have a new generation, healthy new generation with good education and lifestyle changing and will good health. This is our recommendation for now. أعتقد وصلنا إلى آخر توصية. We reach to the end. Thank you very much. شرفتونا. It was our pleasure to have you. شكرا على كل شيء، شكرا على حضوركم وانتباهكم. احنا آسفين على كل شيء ممكن بدر مننا بغير قصد أو خطأ أو تقصير. يعطيكم العافية وشكرا جزيلا. مع السلامة. See you in next year إن شاء الله. See you in next year. مع السلامة. إذا تبون صورة جماعية، اللي يبغى صورة جماعية حيا والله تفضلوا هنا.
كونوا لها فبكم تكون بلد ثراها.
كلوزنج فوتو، اللي يبغى صورة جماعية حيا والله.
قدر لكم أن تخلقون عظماء من بلد عظيم. كونوا لها فبكم تكون بلد ثراها من نعيم. قدر لكم أن تخلقون عظماء من بلد عظيم. يا فخر العرب تاريخ ونسب والمعدن ذهب. سعوديون يا عز عمره ما نضب. سعوديون يا فخر العرب. سعوديون سعوديون إيه سعوديون يا عز عمره ما نضب.
كل الزملاء الاي تي كل الزملاء تعالوا حياكم الله كل اللي موجودين. كلوزنج فود
بالبذل والجود المقيم. خلقا به تتفردون فضل من الله الكريم. أنتم كما الغيث الغتون بالبذل والجود المقيم. خلقا به تتفردون فضل من الله الكريم. يا برق انهمس مروين الظما والنظرة سما. سعوديون دمه قويه وانتما. سعوديون 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 دمه قويه وانتما. كونوا لها فبكم تكون بلد ثراها من نعيم. قدر لكم أن تخلقون عظماء من بلد عظيم. كونوا لها فبكم تكون بلد ثراها من نعيم. قدر لكم أن تخلقون عظماء من بلد عظيم. يا فخر العرب تاريخ ونسب والمعدن ذهب، سعوديون يا عز عمره ما نضب. سعوديون 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 إيه سعوديون يا عز عمره ما نضب. أنتم كما الغيث الغتون بالبذل والجود المقيم، خلقا به تتفردون فضل من الله الكريم. أنتم كما الغيث الغتون بالبذل والجود المقيم، خلقا به تتفردون فضل من الله الكريم. يا برق انهمس مروين الظما والنظرة سما، سعوديون دمه قوية وانتما سعوديون 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 دمه قوية وانتما. كونوا لها فبكم تكون بلد ثراها من نعيم، قدر لكم أن تخلقون عظماء من بلد عظيم. كونوا لها فبكم تكون بلد ثراها من نعيم، قدر لكم أن تخلقون عظماء من بلد عظيم. يا فخر العرب تاريخ ونسب والمعدن ذهب، سعوديون